Now that's recorded. All right. We're doing two different recordings so that I can post it on the YouTube channel so that you guys can have that. In case there's some weirdness that occurs with Doodle, as it tends to. So this week in lab, as a reminder, you will be doing your in the beginning of our lab, you need to bring your computers because we will be taking the module exam for preparatory module. So make sure you have reviewed the level 4 quiz review. Remember, on EMS testing, you have two things that you need to do in order to study for the exam. You need to review the level 4 quiz review, and you need to take the adaptive tests for the module, preparatory module. You can go in and you can select either the education components or you can select the entire module and then just do the prep module so that you get an idea of where you are. Some of you are already doing that, so good on you for having gone and started that preparation. But for those of you who have not, please start doing your study for the module exam. We will take that tomorrow and Thursday. I will be at tomorrow's lab, so as many of you as possible that can come tomorrow, that would be superb. If you don't come tomorrow, then you will have Scott on Thursday and potentially the Alec as well and some other folks that are helping out. But if you can come to Wednesday, that would be great. I'll put that out on GroupMe as well. Always make myself little notes here. So Wednesday would be best if you can. That way I can see your shining faces, number one. And number two, I want to capture as many of you for myself as possible so that I can better kind of gauge where you're going. So this module, if we're looking at the syllabus that we're entering now, is going to be the Airway and Assessment module. So if you're looking on the syllabus as I am right now, you'll see that that's where we are. Assessment we will cover in class for lab. Even though it is a lecture, it's best taught from the lab perspective. So we will cover that. We will do CPR and we will do your assessment this week's lab. So then that will close out both of those areas, airway and assessment. So be prepared next week to take another module exam. So that is how fast we're moving. So as you can see, week 1 and 2, we did prep module and we're taking that exam this week. Week 3, we do patient assessment and the airway module. So we will take that next week. So make sure you are progressing as we are on the syllabus and stay in the game. I don't want anybody thinking that you have lag time because you don't. So I want you to stay on top of it. So today we will lecture chapters Airway, lecture Shock, and I'm going to leave BLS alone because we're going to learn that in lab. And I'm going to leave Assessment chapter alone because we're going to learn that in lab. And then we will take both of those modules. Any questions about that? And I'll put reminders about this on GroupMe as well because they're not all going to be in lecture or watch it quickly. So I will remind everybody about the coming week's agenda. But if you guys could also talk about that on your GroupMe, that would help me out. I know you guys are doing that already. Some of you have sent me text messages about that, and that's very helpful. So thank you. If there's no further questions, let's take roll. Make sure you're ready to key up and tell me that you're here. If someone is on listen only and they say they're here in the chat, could someone that does have a microphone just speak up for them real quick, please? That would be great. And make sure when you say that you're here, that you don't use here, you actually say your name so that I can quickly go down. Remember, I can't see who's talking when I'm on the attendance sheet. So there's that. All right, let's call roll. We do have it as lecture, and today's lecture, let's go with Alejandra. Are you here? Bailey Powers. Blair Tilley. Braxton is here. I see him. Oh, thank God. I thought I was muted, and I would have literally cried after all that talking. All right, Kanaya, or Kanai, James. Wait a minute. Can anybody hear me? I have been literally talking to you guys all this time, only to realize that the system had kicked me out. Y'all didn't hear anything I said, did you? Damn it. That is so freaking annoying. All right, the system is on now. I've double checked it. Anytime I go into OB Studios and I come back into Moodle, because it is such a not up to speed technology, it makes you refresh your screen, which is so silly. And of course, I didn't realize that it wanted me to do that. So, quick down and dirty of what all I said. This week, if at all possible, come to Wednesday's lab. I will be at Wednesday's lab. It's okay if you come to Thursday. Of course, that will be available to you as it is. But I would like to capture as many of you as I can in my own audience so that I can judge your outcomes for this week's lab. Remember that in lab this week, we are taking the exam for preparatory module. So bring your computers. That is the first thing that we will do. We will take the exam for prep module. Then we will cover this week Airway, and we will cover assessment, which are pretty big. We'll also do CPR. So there's a lot going on this week. So please be in the game. There is no rest time right now for the weary. So when we get to the medical module, we'll have a little more space between each thing we're doing. But we do not have that space this week. So please put all your chickens in this bucket for the week because we're going to be heavy on the workload this week. You're doing Airway module and you are doing assessment. Now that may not seem like a lot because they're only a couple chapters apiece. However, they're huge. They're huge dynamics of what you're going to do. The foundation of airway management and shock resuscitation and even CPR, if the shock has progressed to that, that is the foundation of the BLS module. So it will be a lot this week. So if you can at all possible come to Wednesday, please do come to Wednesday. I'll put that out on GroupMe. I know you guys are talking on your GroupMe too, so please help me reiterate everything that I say. Make sure you guys are putting that out on your GroupMe as well, and I'll put out reminders on mine also. So shock will happen this week. Airway will happen this week. BLS resuscitation, which is CPR, will happen this week, and so will assessment. That's what we're doing this week. So we'll get into that. I'm going to call roll. Please speak up if you're here. And remember not to say here, say your name, because I can't see who's talking. And if someone is on listen only, can someone speak up for them, please, if I don't get to them in time? Okay? Alejandra, are you here?
Alejandra Gomez.
Bailey? Blair? I know Braxton is here. Kanai? Caroline Benson? Clayton Cole? Corey Port?
Caroline Benson.
Okay. Clayton Cole, Corey Port, Daniel Moore? Freeman Martin? Is that Daniel?
Yes, sir. Daniel Moore's here.
Okay. Freeman Martin? Isabel?
Okay. Freeman's here.
Okay. Isabel Rice? Jacob Wynn? Jake Glasser, Jonathan Yass,
Jonathan Yass,
Caitlin Overla,
Caitlin Overla.
Kate Stribling, Kelly Wang, Kendall Bloss, I think I saw you, Lauren Anthony,
Lauren Anthony.
Martha Goldsmith,
Martha Goldsmith.
Matt Gaskins, Matt Pierce, Maddie Ryan is Megan Jones, Patrick Olick, Rachel Turner, Tatum, Thais, Thomas Allen,
Thomas is here.
Thomas Catlett, Tiana Whitehead, Tori Fisher, Vanille, Zach Bennett. Is that Vanille?
Vanille.
Okay. And Zach Bennett?
Zach Bennett.
All right. I have Zach. I have Vanille. I have Thomas Allen, Rachel Turner, Martha, Lauren, Kendall, Caitlin, Jonathan, Freeman, Daniel, Caroline, Braxton, Comer, and Alejandra. Double check out here. I see Megan Jones, Oleg, Jones, and Oleg. I see y'all are on listen only. I'll mark you guys. Here is Matt Gaskins here. Okay. So you see the sheet. I see the sheet. No, you don't see the sheet. All right. So this is everybody that I have. You don't see your name. I don't have you. And we're moving on. All right. So we'll start with the airway management chapter. We've already discussed some anatomy and physiology, although we will revisit the anatomy and physiology. We have grossly discussed the anatomy and physiology, so I'll touch a little bit on some things that will continue to pop up in the quizzes and testing, but that part of it you should be already deep in your review of. Today, what we're going to talk about more is the physiology and the intervention. What is the patient going to present like? What is normal? What is bad? And then what do we do about it? So we're going to open that door in the airway module. So if you are with me, turn with your Bibles to chapter 11. Pull up chapter 11. There we are. All right, if you can't see my screen, if for whatever reason the slides aren't up, please speak up and let me know, okay? If while we're going through you have questions, feel free to unmute yourself and ask those questions, and then mute yourself back if you're not currently talking, okay? All right, let's get into it. Your discussion post this week is going to aggressively discuss the difference between respiratory distress and respiratory failure. So as we go through this presentation, I want you to be thinking about what is distress versus failure. Clearly, distress is bad, but it is better than failure. Distress is when our body is still making an attempt to compensate for something bad. When we think about compensation, when you experience an emergency, your body doesn't just say, oops, there's an emergency and I'm out. It tries to fix the emergency or at least buy time until something else can fix the emergency. It is almost as if the body knows that help is coming because it will fight. When it runs into an emergency, it will begin to fight. And you guys are going to be able to see that fight taking place in your patient physically, and that is what will lead you to what the appropriate interventions are. Based on what you're seeing from your patient is how you'll choose what interventions are appropriate to do at that time. So as we go through the material, make sure you are looking for the nuances that differentiate distress from failure. There's a point in which they meet, but they're typically discussed as separate, and what we're going to do for them is separate. So we'll get into our airway anatomy and physiology. We'll get into management. We'll talk about respiration versus ventilation and how we do that in the artificial world when people aren't doing it well on their own. If you also could have your National Registry medical assessment sheet out while we are talking, that will also help this process, which we will build off of extensively in lab this week. Remember to come to Wednesday if at all possible. All right, we already talked about that's what we're going to discuss. We went over some minute ventilation stuff and alveolar ventilation stuff in the anatomy chapter. We're going to build on that a little bit. Pathophysiology, that word. So we have physiology, which is obviously how things work. Pathophysiology is when they go bad. How does that work? What does it look like from the patient when the physiology of breathing and oxygenating goes poorly? We're going to talk about that. Okay? We already discussed last week that the pharynx is the upper airway and the larynx begins the lower airway. That's why larynx starts with an L, because L is for lower. I want to remind you that you're going to see test questions about what is upper and what is lower. In the upper airway, what we're paying attention to is making sure that the passages are clear. So we think about the nasopharynx, we think about the oropharynx. No one is going to breathe very well if the nasopharynx and oropharynx aren't clear. So when you think about what can I do with the upper airway, that is the thought process that you should have. Keep it clear and keep it open. So then we need to talk about how to do that, okay? So in a couple of slides, we're going to discuss how do we keep it clear, how do we keep it open. I want you to look at A on your National Registry medical assessment sheet. A is for airway. And then we have B, that is for breathing. We didn't separate those two without reason. They are separate, although they go together and are looked at together. And if you look on the sheet, they're in the same little block, but they are their own entities. You can have a person who would be breathing if they had a good airway. So breathing is not the problem. Airway is the problem. You can also have a person whose airway is absolutely fine. It's spontaneously patent, but they're not breathing. As is the case of an opiate overdose, someone who may have taken too much pain medication. So, although they go together very well, they are separate. We're going to look at them separately. So I want you to, on your notes for airway, I want you to again put open and clear. Is it open? Is it clear? That is the question that we're asking about the upper airway. All the way down to the hypopharynx. Remember, anything that has pharynx behind it, Pharynx, that is your upper airway, okay? Anything that is in the upper airway, I've got to make sure it's open, and I've got to make sure it's clear. That's the job of A when you look on the sheet for the National Registry Medical Assessment. I should be able from this point on in the classroom to say, talk to me about airway. What are you looking at with airway? And your answer should be, is it open, Justin? Is it clear? So let's talk about what it sounds like and looks like if it isn't open and it isn't clear. So you need a note section for open and you need a note section for clear. Okay? When we talk about the airway being open, we literally mean, is the physical anatomy of the airway obstructing it? Is the nair closed? Is the back of the tongue actually sitting on the glottis, preventing air from moving in and out? Test question. The tongue is the most common obstruction of the airway. So the trigger words that I want you to develop in your head for open is stridor. Stridor is a high-pitched noise that indicates the tissue of the upper airway is closed. It's swelling and it's not allowing air to freely pass. Stridor is a high-pitched squealing noise, S-T-R-I-D-O-R. Stridor. When you think about is it open, you ask yourself, is the patient freely moving air? The number one way to know that that's not happening is you hear noises. You hear noises. Those noises are stridor and snoring. Stridor indicates that there's some type of physical obstruction of the upper airway and it's making this high-pitched squealing noise. When the patient goes to breathe, it sounds like a squealing noise. Okay? Snoring indicates the tongue is obstructing the airway. You've got to know that. You might see test questions that say, you hear sonorous respirations, what can you do? The answer is you've got to open the airway because it isn't open. The tongue is obstructing the airway. So from now on, when you think about is the airway open, your brain should think about, do I hear a stridor? Do I hear snoring? Is the patient freely talking to me? Because if the patient is able to talk to you and there is no stridor, there are no snoring respirations, then the airway is spontaneously patent. Air can freely move in and out of the airway. So when you think about airway, your questions are, is it open? Is it clear? In regards to open, do I hear a stridor? Do I hear any snoring? From this moment on, if you were to see any test question or if you were to see any presentation in lab where we say the patient is snoring respirations, you should immediately think the tongue is on the back of the throat and is keeping air from going into the patient. Snoring equals tongue obstruction. Stridor equals the airway is physically closing from edema, restriction, like anaphylaxis. Okay, stridor would, your most common reason for stridor would be anaphylaxis, where the throat is closing because of this extreme allergy response. And then there's the potential that you've got something in your airway. Hold on just a second. Let me make sure I'm good. Okay, is everybody still with me? Everybody still with me? Looks like I had a restoration. We still good? Okay, good. My last comment was about snoring and stridor. Did everybody hear that? Yes. So I put in the comments up here that when you're thinking about airway, your question is it open? And the answer is, if the patient is freely talking to you, then yes, it's open because they have spontaneously patent airway. They're talking to you. However, if they have any odd noises like stridor or snoring, then the airway is not open. Okay? So stridor, we remind ourselves, is a loud pitched squealing noise that indicates the airway is closing. Think anaphylaxis. Think foreign body airway, like something stuck in their throat. Okay? Snoring equals the tongue is obstructing the airway. You would think of someone who's not very conscious, who's maybe supine, laying on their back. Their tongue would be obstructing the airway. So if you hear stridor from now on, you need to know that the airway is not open. If you hear snoring from now on, you need to know that the tongue is obstructing the airway. And we're going to learn what to do about that. Okay? Those are upper airway concerns. For lower airway concerns, we'll get to those in a little bit. Let's talk about clear. We talked about open, okay? So we're dealing with the upper airway, pharynx. We're dealing with the oropharynx, we're dealing with the nasopharynx, we're dealing with the hypopharynx, which is right where my little hand and red blip is on the screen here, okay? The hypopharynx, if it's not clear, you're going to talk about secretions, okay? So open is about whether or not you have a stridor or whether you have snoring. Clear is whether or not the patient has secretions, blood, vomit, saliva. Most people can clear their own secretions, but if the patient can't clear their own secretions, then you would hear gurgling. So if I told you the patient is snoring, then you need to open the airway. If I told you the patient is gurgling, then you should immediately think to suction the patient's airway. So I'm trying to give you trigger words of a problem, and then you're trying to attach a solution. So the trigger word for open is stridor. The trigger word for open is snoring. And the answer, the solution, would be to open it. And we'll learn how to open it. In the clear aspect of airway, you're thinking about gurgling, which is blood, saliva, vomit, secretions that are preventing air from moving in and out of the patient. And the solution would be suction that crap out of there. So on the sheet, looking at the National Registry Medical Assessment sheet, you see airway, and your question is it open? Is it clear? If it wasn't open, you'd hear a stridor. You'd hear snoring. If it wasn't clear, you hear gurgling. And now you know what to do about all of those things. We're going to talk more in depth about it, but if you need an open airway, then open it. If you need a clear airway, then clear it with suctioning. Any questions about that? Does any of that need to be reviewed? Victoria's typing. Okay. So, we'll move on from that section right now because I don't want to talk about the lower airway yet. So, on your assessment sheet, make sure you have those little components down. Open and clear. Okay? Let's get into a little more of the breathing aspect of the patient. We're going to go into B. Okay? We did some A. We're going to go into B. Can anybody tell me from last week, what is it that we look at in the primary assessment for B? What do we assess? There was an acronym that we gave. What is the acronym for B? How do we assess the patient's breathing in the primary with an acronym? Rate, rhythm, and quality. So that was how we established normal. The rate should be 12 to 20, the rhythm should be regular, and the quality should be unlabored. Breathing is passive. It doesn't require a lot of work, so it should be unlabored. We shouldn't be able to physically look at the patient and say, well, goodness, they're having trouble breathing. When someone's having trouble breathing, you can physically see that in the patient. It looks like they're having trouble breathing. They're breathing fast. They're maybe sitting upright so that they can get as much air as possible. Maybe they have their hands on their knees and they are doing what we call the tripod position, where they're trying to get as much air as they can by elongating their thorax. They're trying to sit upright as high as tall as they can so that they can get more air. That would be a sign of someone having trouble breathing. If we were looking at them without their shirt on, we would see some accessory muscle breathing. You need to remember that. Accessory muscle breathing means that we would start to see the bones when they take a breath because the muscles are getting tired. And when muscles get tired, they start thinning and they reduce in their thickness, something we would refer to as acute atrophy. They actually physically aren't as strong. So you start seeing way more bones and way less muscles in the chest, which is abnormal. So if you're looking at someone's chest and they're breathing at a fast rate and they look like they're working hard to breathe, we call that labored. All right, we call that labored. And from this moment on, if you see labored breathing, the solution is give them oxygen. And we're going to say give them high flow oxygen. And we're going to define that in a little bit later. So we did A. Now we're in B. Okay? In A, we said, is it open? Is it clear? Well, if it's not open, I'll open it. We'll talk about the ways that we can do that. If it isn't clear, well, then I'll clear it by suctioning the airway. Now we're in B, and we say to ourselves, I'm going to physically look at the patient, and I'm going to assess the rate, the rhythm, the quality of their breathing, and I'm going to look at that chest, and I'm going to say to myself, does it look like they're working hard to breathe? If they are, then that's called labored breathing, and I need to give the patient oxygen. We're going to talk about how to do that in just a minute. The answer to labored breathing is high flow oxygen. That's a test question. The other version of breathing is when the patient is no longer breathing well enough on their own, and we should breathe for them. We're going to call that shallow. Shallow equals ventilate the patient. From this moment forward, if anybody describes the patient's breathing to you as shallow, you should most likely be ventilating the patient. These are trigger words. They're trigger words in your actual test taking on the computer. If you saw labored, give them oxygen. If you see shallow, ventilate the patient. Choose the question answer that ventilates the patient. Labored equals oxygen. Shallow equals ventilate. What do we mean by shallow? We said last week that tidal volume equals chest rise. When I'm looking at someone's breathing, I can physically see if their chest is rising and falling with each breath, and it should. If the chest is not rising and falling with each breath, or I feel like there's very little rise and fall with each breath, then maybe it's time to ventilate the patient. So from now on, labored equals high flow oxygen, and shallow equals ventilate the patient. Yes, Braxton, shallow breathing is about the volume of air. And if they don't have enough volume of air, then we can give them volume of air. We'll get into a little bit more discipline of that, Zach, in just a little bit. We'll get there, Braxton. We're not there yet. I want you to learn the triggers. I want you to focus on the words right now so that if they're said out loud to you, or if you see them in a quiz or on the module exam, you understand what the answer should be. These are trigger words. I give you a trigger, you give the solution. If you hear the trigger of labored, your solution is high flow oxygen. If you hear the trigger of shallow breathing, then your answer would be ventilate the patient. Those are triggers. Okay? So we did A, we did B. We know what to do for the triggers. Let's get into the actual physiology of that. Okay? Let's get into digging into that a little bit more. You already know the anatomy. I'm going to work my way out of that. We already talked a lot about that in the oropharynx. I do want to again show you the big old tongue. You only see a very little amount of the tongue for what is actually there. And the tongue is the most common obstruction of the airway. If a patient starts declining in mental status, if they get sleepy and they lay on their back, their tongue is going to cover the airway and it's not going to let the patient breathe. So then we would hear snoring. The ventilations are going to continue to try and happen. And that continue to try is going to produce snoring. So when you hear snoring, think, I need to open that airway. Let's get into how you would open the airway. I'm going to move past this anatomy because we already covered it. So make sure you're reading on that. We'll keep covering it. Okay? Let's get into, I'm going to come back to that. Let's get into how we open the airway. So if this patient who looks unconscious or sleeping or whatever's wrong, maybe they're drunk, maybe they overdosed, maybe they had a seizure, maybe they had a heart attack, maybe they had a stroke, but they're not very conscious. And so then the tongue is going to rest on the back of the throat and it's going to keep the patient from breathing. The first thing we could do to open it would be a head tilt chin lift, and we're going to cover that in lab. But a head tilt chin lift would be one manual way to open the airway. You would literally just take the chin and try to move it towards the patient's eyeballs or towards the ceiling. You need to take the chin and move it back and up. A head tilt chin lift should be used to manually open the airway of a patient when you hear snoring. You also only use a head tilt chin lift if the patient has no signs of cervical trauma. Because a head tilt chin lift requires us to move the patient's neck backwards, you're taking the chin and you're rocking it backwards towards the ceiling, towards the patient's eyeballs. Okay, you're going backwards. Well, you don't want to do that on someone who has a spine problem. So remember that head tilt chin lift is for patients who you do not suspect have any trauma of their spine. Okay? If they did have trauma in their spine, then you would do a jaw thrust maneuver, which is this picture here. Again, we're talking about opening the airway. When we get to A, we say, is it open? Is it clear? If it's not open, the patient is snorous respiration. We hear a snoring sound. Well, then manually open it by using a head tilt chin lift for people who don't have trauma and using a jaw thrust for people who do have trauma. That's the test answer stuff. When should you use a jaw thrust? When the airway is not open and the patient is suspected to have trauma. I would use a jaw thrust. If the airway is not open and there is no trauma, I would use a head tilt chin lift. That is how you would manually open the airway. Now, here's the problem with manually opening the airway. We're back in A. We're thinking about open. Is it open? Is it clear? Head tilt chin lifts and jaw thrusts close the airway again the moment that you let go. You can't hold those positions for very long, and you certainly can't hold those positions while you're doing other things. So it's meant to buy you time, and it buys you time until you can get to an adjunct. We said if the airway wasn't open, then open it. This is a manual way to open it. But that isn't going to keep the airway open. You're going to have to use an adjunct to keep it open. So if the patient wasn't keeping an airway open once you open it, then we're going to insert an adjunct. The first adjunct that we could insert is an OPA, an oropharyngeal airway. So we did a head tilt chin lift on them, and we now are going to move to an adjunct because we know that a head tilt chin lift doesn't keep very long. This is an OPA, a piece of plastic that goes in the mouth and holds the tongue off of the back of the airway. We said the tongue was the most common obstruction of the airway. An oropharyngeal airway merely keeps the tongue off the back of the airway. As you can see in this diagram, the entire point is to put this in the mouth and keep the airway open. As you can see, it goes to the base of the tongue. That's the bottom jaw there. You put it into the base of the tongue and it keeps the tongue off the back of the airway and it allows air to move through. Here's the problem with an OPA, an oropharyngeal airway. You can't use it on patients who have a gag reflex. One of the last things to go away when we become unconscious, no matter what the cause is our gag reflex. Most of us, if you put your finger down your throat, you'll immediately start to gag. And if you did that long enough, what happens? If you did that long enough, what would happen? You would vomit, which is the word emesis. Thank you, Tori. You would vomit. And so if you had a problem with the airway being open and then you added another problem of vomit to it, you now have an airway that isn't open and an airway that isn't clear. It's our goal not to make things worse. So you can't put an OPA in someone who has a gag. There are people who are not conscious. There are people who are not awake. They're not alert, but they still have their gag reflex. So if you're going to keep an airway open, you could try an OPA, an oropharyngeal airway. But if the patient started showing you that they had a gag reflex, you would take it out. So how do you know? Your answer now is probably, well, how do I know a person has a gag reflex? The same way you would know from if you stuck your finger down your throat right now. You'd start hearing them gag. So maybe they're an overdose patient and they're not awake enough to start going, right? You got to look at their throat. If you put that OPA down and their throat starts moving, you start seeing swallowing, you start seeing this movement in their throat, that is the gag reflex. You should take the airway out. Okay? So then if that was the case, if you had to take the airway out, your next option would be an NPA, a nasopharyngeal airway. I have no idea what came up. Let's get out of there. So a nasopharyngeal airway is what we would use if they had a gag reflex. There are people who are still too conscious for that particular plastic to go in their nose. So you would put it in, if you put an OPA in and they started gagging, you'd take that out and you'd put this tube down their nose. Okay? Here's the tube. There's your tube. We're going to learn this in lab. So again, if I had to manually open the airway, it's not going to stay open. You got to put something in the airway to keep it open, to keep the tongue off the back of the throat, to keep that airway open. Your two options are oropharyngeal airways. Well, that makes sense because the mouth is first. Or nasopharyngeal airways. If you're putting in an OPA, it's because the patient doesn't have a gag and they're unconscious. If you're putting in an NPA, I would suspect it's because the patient's not very conscious, but you did find a gag. When you put that OPA in, they started moving their throat around, and so you got worried about their gag, and you took it out. This is what we hope is occurring in a patient that we placed an OPA in. We're hoping that the piece of little tubing here will go past the base of the tongue, and so at least for the diameter of this tube, air is moving in and out. Okay? So what do we do to keep airways open? Well, we start by manually opening the airway. We start by manually opening the airway. Then we have to put something in the airway to keep it open. The answer is either an OPA or an NPA. OPAs are for people who aren't conscious and do not have a gag. These are your most sick patients. OPAs are for the sickest patients. An NPA, nasopharyngeal airway, is for a patient who is still pretty unconscious, but they are not sick enough to have lost their gag reflex. Airway. Is it open? Is it clear? If it isn't open, I can do a head tilt chin lift or a jaw thrust. I would do a head tilt chin lift if there's no trauma, a jaw thrust if there was. That isn't going to last very long, so I need an adjunct. I need an oropharyngeal airway or a nasopharyngeal airway. I would try the oropharyngeal airway first if I thought the patient was really unconscious, and I would make sure that the patient accepts it by not presenting with a gag. If you put in the OPA, the patient shouldn't begin gagging. If they don't gag, then good. The patient has accepted the airway. If they do gag, take it out to prevent them from vomiting and put in a nasopharyngeal airway. Now we'll work on how to do that in lab. What I want you to work on right now is understanding didactically that if I find this, I should do this. If I find this, I should do this. Okay? So we have now covered the open component as far as to what interventions you should be going for. Let's look at the clearing component. What noise did I say would trigger you to clear the patient's airway? What noise, what trigger word did I say we would use to clear the patient's airway? Yes, Megan, stridor, which would be a high-pitched squealing noise. We'll talk about that later. But gurgling is the trigger word for suction. If you hear gurgling, it's coming from saliva, blood, vomit, and we would fix that by clearing the airway, by suctioning the airway. Let's look at how to suction the patient. Number one, patients in recovery position are self-clearing and self-opening. So if you're wondering why the book is going to constantly say recovery position is good, recovery position is good, it is because you can keep the airway open and clear in this position. I showed everyone a video in class of the RSI that took place in Pierce County, Washington. In that RSI, when they moved the patient from the side of the road in the grass to the ambulance, they kept the patient in recovery position because she was actively dry heaving, she had been vomiting, and she was not very conscious. She still had a gag reflex, but she wasn't very conscious. Not conscious enough to clear her own airway. So that is why they kept her in recovery position. If you don't know what video I'm talking about, then go to YouTube and simply type in EMS RSI and you'll find it. It was on the Night Watch version of EMS. We watched it in class. That was a good example of recovery position. Self-opening and self-clearing. Let's go back to clearing. If it's not clear, we hear gurgling, we're going to clear it by suctioning the patient. Tomorrow and Thursday in lab, we will discuss and show you and let you practice how to clear an airway. Simply put, you would do the same thing as you did with opening the airway. You could go through the nose or you could go through the mouth. Nasopharyngeal suctioning, oropharyngeal suctioning. Nasopharyngeal suction goes through the nose. Oropharyngeal suction goes through the mouth. Not complex. Maybe the words just sound complex. If you're going through the mouth, then you would use this rigid catheter that you see in B and C. A hard plastic catheter that would be inserted as far back in the mouth as possible. You would begin suctioning on the way out, if at all possible, for no more than 10 to 15 seconds. That's a test question. You're going to need to know that. We don't suction patients forever and ever, amen, because you could take out some good oxygen. We'll talk about that in class. I don't want to dig that too deep right now, but there are some bad results to over-suctioning people. With that said, you have to suction the airway until the airway is clear. So if the airway continued to foul, you would continue to suction. When we say foul, we think about blood. We think about vomit that's coming. It's actively coming up. If it keeps doing that, you'd keep suctioning. But if it doesn't keep doing that, you wouldn't suction for longer than 10 to 15 seconds. You need to remember that. Generally for adults, it's 10 to 15 seconds. Generally for kids, it's 5 to 10 seconds. And generally for infants, it's no more than 5 seconds. I'll let you write that down. Those are good notes. So in class, when you demonstrate suctioning a patient, I expect you to say, I would put the catheter in the patient's mouth as far back as I can see. I'd begin suctioning, coming out, and do it for no more than 10 to 15 seconds. So if it isn't open, you now know how to open it, didactically speaking. If it isn't clear, you now know how to clear it, didactically speaking. You can go through the nose to clear it. You can go through the mouth to clear it. And we're going to talk about that and show you that tomorrow. The book here is calling for no more than 15 seconds. Okay? So tends to be less in young children and all the way up to 15 in adults. With the caveat being that if the airway continues to foul, then you continue to suction. And that would be someone who's actively bleeding. That would be someone who's actively vomiting. Then you would continue to suction. You're going to see a test question that says you have a supine patient on your stretcher. Supine means on their back. The patient suddenly begins to vomit. What do you do? The answer is immediately move the patient to recovery position and then suction the airway. It will not happen well enough for you to leave the patient supine and suction them in time to prevent aspiration. Aspiration is getting vomit into your lungs, sucking bad stuff into your lungs. If someone begins to suddenly vomit and they're lying on their back, you won't be able to suction them fast enough to clear their airway. You need to first move the patient onto recovery position. Second, suction the patient's airway. The test question wants you to know that you need to go to recovery position as fast as possible to prevent any immediate aspiration. Then, suction the patient's airway. Are there any questions about how to find out an airway is not open and then how to manually open it? Find out that an airway isn't clear and then manually clear it. Are there any questions about that? Zach Bennett says, what cue tells you to use nose suction versus mouth suction? Very good, Zach. If I couldn't get in the mouth. There are times when patients experience emergencies where their mouth will close shut and you can't get it open. They'll clench their mouth together. Think about seizures, some types of heart attacks, some types of heart arrhythmias where the rhythm in the heart goes bad, some types of strokes. Whatever happened with that patient at that time and their mouth shut and you can't get it open, then you would go through the nose with a soft tip suction catheter, which I don't have to show you right now, so I'm going to show you in lab. So we're going to review that in lab. If you were doing it orally, your catheter would be a rigid catheter. It would be a hard piece of plastic. If you're going through the nose, obviously the nose is more delicate. Obviously it's smaller. So then you need a soft catheter that can kind of go down the flow of the nose, kind of similar to the nasopharyngeal airway tube that we looked at. The only big difference is it has suction on the end of it. Okay? Yes, you can use it for the same amount of time. And I'm going to teach you how to do both of those techniques. So I don't want you to focus on that right now. I want you to focus on when to do it. Okay, I got you back. Stupid internet here at this. Okay, I got you back. Stupid internet here at this multi-billion-dollar company is not up to multi-billion-dollar quality. So as we were saying, you would use the nasosuctioning if the mouth was clenched, and you would do it for the same amount of time. We're going to learn those techniques in lab, so I want you to focus right now on when you would do it, not how you would do it. I'm going to teach you the how in lab. Today, learn when to do it. So you would use the mouth if the mouth is open and available with a rigid catheter, a hard piece of plastic. You'd use a soft tube to suction the nose when you couldn't get into the mouth. The most common time for this is seizure patients.
You are now muted. You are now unmuted.
The most common time to use nasopharyngeal suctioning is in a seizure patient. Okay? Any more questions about manually opening the airway, airway adjuncts, the oropharyngeal airway and the nasopharyngeal airway, and suctioning the airway, whether that is oropharyngeal suctioning with a hard catheter or nasopharyngeal suctioning with a soft catheter? Okay, so we introduced A. We've now elaborated on A. We've now said what it looks like to be bad and what to do about bad. We introduced breathing. We said its rate, rhythm, and quality. We look at the chest physically with our eyeballs. Does it look like they're working hard? Does their chest muscles scream, I need help? And we said, if it's labored, oxygenate them. If it's shallow, breathe for them. We've covered A. Let's get deeper into B. Let's take a break first. It's 9:07. Let's come back at 9:15. I'm going to move my computer to a better internet source, and you're going to come back at 9:15. Grab a drink, go to the bathroom, and we're going to dig into how to oxygenate and how to ventilate the patient. 9:15.
You are now muted. You are now unmuted.
All right, children. Let's get to it. All right. We said when we come back, we would start on how to oxygenate and how to ventilate. So let's get into that. Oh, let me close the door. So if a person's breathing looks like it's increased in work, they're having trouble breathing, it's visible to us that they're having trouble breathing. Maybe they're tachypnic, which means breathing fast. You need to really learn that word, okay? Tachypneic, which means tachypnic. I'm trying to type it for you here. Tachypnic means fast breathing, and so the patient is above 20. So if the patient is breathing 26 times a minute and you look at them physically and it looks like they're working hard to breathe, that's called labored breathing, and we should oxygenate that. Okay? In this room that I'm in and in the room that you're in, we're all breathing an FiO2 of 21%. You need to know that. FiO2 means fraction of inspired oxygen. It can show up as a percent or a decimal. It can show up as a percent or a decimal. In natural air, we are breathing 21%, whether you're at sea level or whether you're on the top of a mountain. There's 21% atmospheric oxygen. We can talk about why that's true, and if you don't think it is, I will be happy to take that on with you in lab and talk to you about Dalton's gas law and the other laws that apply to the 21% rule. We're all breathing 21%. You need to know that that's true. Well, if our patients are labored in breathing, if they're tachypnic, if they're showing signs of trouble breathing, and they're labored, we're going to supplement that 21%. That's what it is when we give people oxygen. Supplementation. We can supplement people's oxygen all the way up to 100%. FiO2. So, we're breathing 21%. If we run into trouble, that's not enough. We can give them oxygen. And we can give them oxygen all the way up to the air that they just took a breath in for now has 100% oxygen in it. That would be shown as an FiO2 of 1.0, which is 100%, or a percentile, 100%. Let's talk about how we oxygenate people. You need to know this fraction of inspired oxygen conversation. We're going to use an oxygen tank to give the patient oxygen. Okay? We're going to turn the oxygen up based on what device we're using. Okay? So let's go over to the devices. We'll learn these in lab. But the options are a nasal cannula, which can breathe for a patient from 1 to 6 liters per minute. Liters per minute is how much oxygen is flowing. You put the oxygen tank connected to the cannula, and then you turn the dial up to 1 liter, 2, 3, 4, 5, or 6. So 1 to 6 liters per minute is what I would expect from a nasal cannula. This is a person who just needs a little love. This is not a person who is sick. 1 to 6 liters is not considered high flow. I said that if a patient was labored, if a patient looks like they're having trouble breathing, you should give them high flow oxygen. The device that we would use for high flow oxygen is a non-rebreather mask. Non-rebreather mask. Your book has pictures of these. We're going to learn what they look like and how to physically use them tomorrow. A non-rebreather mask would go from 10 to 15 liters per minute. I want you to just focus on 15. 15 liters per minute from now on will be considered high flow. "15 liters per minute from now on will be considered high flow." If a person is in distress, they need high flow oxygen. So you wouldn't use a nasal cannula. On anyone who's sick, anyone who's worrying you, anyone you consider emergent, you wouldn't be using a nasal cannula on that person. You would use a non-rebreather mask. We're going to look at this in class. We're going to talk about it in class. Right now, I want you to commit to the, if I see this, I should do this approach. So a non-rebreather mask is 10 to 15 liters per minute. Nasal cannula is 1 to 6 liters per minute. And then a bag valve mask, which we would use to breathe for someone. If I'm going to breathe for you, if I'm going to ventilate you, I would use a BVM at 15 liters per minute. Isn't that cute? You don't have to have a BVM on oxygen, so I'm going to test you a little bit. If you were using a bag valve mask to ventilate someone, let's go look at a bag valve mask. If you were using a bag valve mask to ventilate someone, it's the ambu bag that you see on Grey's Anatomy, right? We're going to learn how to use this. If you're using this to ventilate someone and you didn't attach it to oxygen, how much oxygen is the patient receiving? If you were using a BVM, very good. Either 0.21, which is the same as 21%. We're breathing 21%. If you use a BVM in the normal atmosphere of the room and you don't have it attached to oxygen, then you would be breathing for them at 21%. As you can see by the picture here, okay, the bag valve mask has a oxygen tube and a little oxygen reservoir bag that you could hook up to the oxygen, but you don't have to have it hooked up to oxygen. If you were using just the bag and the mask to ventilate a patient and there was no oxygen, it would be on 21%. If you attach that to oxygen, I would expect you to attach it at 15 liters per minute. So pretty much, Caitlin, you can't see the picture. Does anybody else see the picture? Can everybody else see my screen? Okay, I'm not sure what's wrong with yours, Caitlin. Maybe refresh your screen. Okay, maybe refresh your screen. So, if you're using 21% with a BVM, there's no oxygen. If you're using oxygen, it should be 15 liters per minute. So, here's how you quickly memorize all that crap. If you're giving oxygen to a person who's actually sick, they're labored, they're shallow, they're emergent, they're bad off, they're showing signs of shock, then you should have it on 15 liters per minute. Just commit that number to memory as the number you would use for people who are sick. 15, 15, 15, 15, 15. If someone is sick, I want to give them oxygen, I'm going to give them oxygen at 15 liters per minute. You wouldn't use a nasal cannula on someone who is sick because it doesn't have enough flow. There's not enough oxygen coming out of it. You would use a non-rebreather mask for people who are breathing on their own to supplement their oxygen. You would use a bag valve mask for people who are not breathing on their own to supplement their oxygen. So we have a BVM for people that we want to ventilate. We have a nasal cannula for people who just need a little love, right? They just need a little love. That connects to the oxygen tank, and that goes in their little nose. And when they breathe, big breath in through their nose, they get some oxygen. That's for people who need a little love. But if they were sick, you'd be using a non-rebreather mask or a BVM. Here's the non-rebreather mask. Goes on the face. There's an oxygen reservoir bag. The oxygen is coming from the bag. When they breathe in, they suck in the oxygen. Okay? So, what liters per minute of oxygen would you put on a patient you believe to be emergent? Beautiful. 15. Commit that number to memory. If anybody is sick, that's what we would use. Okie doke? Double check that that's on. It is. Okay, good. Carrying on. There's so many systems to keep an eye on. So, we said in B, in breathing, we would physically look at the patient for rate, rhythm, and quality. If they're tachypnic, if they're labored, if they're speaking in broken sentences because they're so tachypnic that they can't get enough air to speak in a full sentence, that's called 2 to 3 word dyspnea. If they are tripoding, they're putting their hands on their knees and they're holding their chest as open and as tall as they can. All of these signs suggest the patient is having trouble breathing. If the patient looks like they're having trouble breathing, put them on oxygen at 15 liters per minute. If the patient weren't conscious and doesn't have good tidal volume, we would call that shallow breathing, and shallow breathing gets ventilated. Are there any questions about what a bad airway or bad breathing looks like? And are there any questions about what we would do for a bad airway or bad breathing? Yes, you are still ventilating. The ventilation component is when you squeeze the bag and the air goes into the patient's lungs and their chest rises. That's not oxygenating, that's ventilating. Okay? You would most likely be using a BVM attached to oxygen. You should attach the BVM to oxygen as soon as you can. What I don't want you to think is that you can't go ahead and use the BVM if you don't readily have oxygen available, because you can. In fact, in the overdose population, patients who have overdosed on heroin or pain medications or sedatives, and now they're so sleepy that they don't want to breathe, their problem is not oxygen related. They don't have an oxygen problem. The oxygen is the same in the air as it was when they took that medicine or when they injected that drug. They don't have an oxygen problem. They're simply not breathing. So if you would breathe for them, the 21% that we have in the room would work. So as we dig into this, we're going to look at our patients and say, is this an oxygen problem or is this a ventilation problem? And in the case of an overdose patient, you would get that BVM out as fast as you can and you would breathe for that patient, whether you did or didn't have it attached to oxygen. And the moment you can attach it to oxygen, you would. Any questions about that? Raise your hands if you're hearing me fine. Just make sure you're live out there. Okay, good. So, I think we have a good grasp, didactically speaking, on giving oxygen, what devices we would use, how do we open and clear airways. Let's talk about the FiO2 capabilities of each device. Okay? You're going to need to know this. FiO2 of a nasal cannula is double what you're breathing in this room. It can take you up to about 45%. That's easy to remember. So a nasal cannula can basically double your FiO2. I want you to remember it that way. A nasal cannula can basically double your FiO2. Alec, are you still with me? Can everybody else hear me? Okay, I'm just making sure. Good. So it's probably on your side, Alec. Sorry. So nasal cannula can basically double your FiO2. A non-rebreather, the book will say, will get you up to about 95% FiO2 if it's a true non-rebreather. And tomorrow when we look at the non-rebreather, I'll show you what those words mean, to non-rebreathe. That isn't just a name, it has a meaning, it has a function. I'm going to show you what it means to non-rebreathe. And if they are not rebreathing the same air as they exhaled, you can get them up to 95% on a non-rebreather, which is really good. That's a pretty high FiO2. And as far as a BVM is concerned, with a great seal, meaning you're getting a really good seal to the patient's face with the mask, you can get up to 100% FiO2. You're going to see test questions about FiO2, fraction of inspired oxygen. You're going to see test questions about the room air FiO2, which would be 21%. You're going to see questions that say, how much FiO2 could you expect from a non-rebreather? And the answer would be up to 95%. What is the maximum FiO2 you would expect from a nasal cannula? And the answer would be about double the room air. So somewhere between 42 and 45%. Any questions about the FiO2 capability of these delivery devices? Okay, good. Let's carry on. There are some of your pictures. We talked about FiO2. I'm not going to talk about Venturi masks, but all that is, just so you know, is you can actually take these little additives and select the specific FiO2 you want. I'm not going to talk about that, though, because you aren't really going to be using those in your 911 practice as an EMT. You might see that in the private world where you're transporting patients from facility to facility, but you're not going to see that in general. Okay? So I'm going to leave that one alone. You are going to see a lot of questions about patients with tracheostomies. I just want to remind you that a tracheostomy is where someone has a direct access to their trachea. Instead of having to breathe just out of their nose and mouth, we have put a tube directly into the trachea, and they're breathing from the outside world directly into the trachea, which reduces the amount of work that they need to undertake in order to get the same breath. If you're wondering, why do we put in tracheostomies? Well, there are lots of reasons. Maybe their trachea is injured. Maybe we can't get them intubated. But one of the reasons we put tracheostomies in patients who have been in the hospital for a long time or are going home with extensive care is because it takes less work to breathe from a tracheostomy than it does from your nose and mouth because there's less space. That just makes sense. But people get pretty scared about tracheostomies. You shouldn't be scared of them. They actually are very helpful, and it's a direct access to the trachea. So you're going to see a lot of questions about oxygenating and ventilating patients who have a tracheostomy. You need to know that there's a little tube right here where my little red pointer is. That's a tracheostomy tube, and it goes into the patient's trachea, and there's a little balloon that we blow up in there to keep it from popping out. So it's a very small little tube directly in the trachea. No big deal. But people are pretty fearful of them. You shouldn't be. You can put oxygen on it, just like you would the patient normally. And you can also ventilate it by taking the mask off of your bag valve mask and just attaching the bag itself to the tracheostomy and squeezing it like normal until you see chest rise and fall. Okay? So if this patient wasn't breathing, I would take the mask off my bag valve mask. Here's the bag valve mask. Okay, let me go back to my share screen. I would just take the mask off and I would use just the bag here. Attach that to the tracheostomy tube and start ventilating the patient. When we squeeze the bag, we squeeze it until the chest rises. When the chest rises, you know that you've given a breath and the patient is now being ventilated. You're going to see a lot of questions about tracheostomies. Number one, the biggest issue with a tracheostomy is that mucus starts to occlude it. Because this is directly accessing the patient's trachea, you don't have the protective mechanisms that you normally have when air enters your body. When you breathe through your nose and mouth, the air is put through a rigorous warming and cleaning system, mostly the nares of your nose, going down the back of the tubules that go into the nasopharynx. When that air is moving through there turbulently, it's being cleaned and it's being warmed so that by the time it reaches your trachea, you're breathing what we hope is sterile air. And I use the word sterile loosely. When we put in a tracheostomy, you don't get to clean the air. So then you start developing a lot of mucus. If you didn't know this, the reason we have mucus is because we surround little bacteria and viruses in the mucus, and then you cough up the mucus, and then you reduce the amount of bacteria and viruses. And whether or not you become infected by something is only about not because you were exposed to it, but because how much of it you were exposed to. So the mucus's job is to reduce the amount of virus, reduce the amount of bacteria, and thereby, hopefully, reducing the amount of the invasion of that bacteria or virus. So the number one problem with tracheostomies is that they get too much mucus around them, and it will keep the air from moving in and out. Well, here's a little bit of a problem for you. EMTs cannot soft catheter suction tracheostomies, which I think is stupid. But you can't. You're not allowed to put a soft catheter through that tube and suction the patient, which I think is a little silly. All you have available to you is your rigid suction, which can get in and around the tube a little bit, but not very much. But here's some help. When patients go home with tracheostomies, we train their family to sterile suction their trachs. We train their family to put soft tip suction catheters down the tube and suction out the bad mucus. So you should employ the family to help you if you believe that mucus is messing up the tube and that's why the patient is in distress. Number one, you should have the family suction the tube. And number two, you should oxygenate the tube by putting a non-rebreather mask over it at 15 liters per minute, or ventilate it with a bag valve mask if you need to. Give me 2 seconds.
You are now muted.
Hey, baby girl, I'm teaching class. Can I call you back in a little bit? Yeah. How's it going? Hi, Donnie Grace. Oh, that's really fun. Well, I love you and I miss you. I'm going to call you on my next break, okay? I'm going to call you on my next break. I love you. Bye-bye.
You are now unmuted.
Sorry, that was the daughter. So the family can suction it, and then you can oxygenate it, whether you're oxygenating it with a non-rebreather mask or whether you're going to actually ventilate the patient because maybe they're that sick. They're not getting good chest rise and fall. They're not getting good tidal volume. And so then you're going to breathe for them with a bag valve mask that's attached to oxygen. Those are your options. But use the family to clear the tube because mucus is normally the problem. Okay? You're going to see test questions that address the potential for the tube to come out. If a patient coughs really hard, they can blow the tube out, which is funny, but not really. And then they run into trouble breathing. You can ventilate the stoma. The hole that we created to put the tube in is called a stoma. The tube itself goes into the stoma. If the tube were to come out, you could still ventilate the stoma. You could put a pediatric mask on your adult bag valve mask and put it over the hole and ventilate the patient just like you would have done if you were using their face with a normal mask. You're going to see test questions that ask you about that. If you have an adult patient who needs to be ventilated via their stoma, put a pediatric mask on an adult BVM and ventilate the patient by pressing the mask over the hole and squeezing the bag until you see chest rise and fall. Are there any questions about how to ventilate an adult tracheostoma with a bag valve mask should the tube get dislodged or come out? Are there any questions about that? Okay, good. Raise your hands if you're still with me. Very good. Just checking on you. I want you to focus in your reading on tracheostomies. The word ostomy means we poked a hole. Trachea is just where we did it. Trachea, hole. I want you to focus your reading there because you're going to see a lot of questions about it. I want you to be prepared for those questions. Why do you see a lot of questions about this? Because it scares the hell out of people. And when people get scared, they don't do good things, they do no things. They just freeze. They clam up and they do nothing. They grab the patient and run to the ambulance and then run to the hospital. Well, that's not going to work. You can't run with patients just because you're scared. You've got to do what you're told and trained and taught to do. So that's why you're going to see a lot of questions about tracheostomies. You can put a non-rebreather on it. You can have the family suction it. You could suction the outside of it and in and around the actual opening of the tube. And you could ventilate it if you had to ventilate it. Remember that we always ventilate people, no matter what method we're using, only enough to cause chest rise and fall. Let's get to another set of questions you're going to see a lot about if you're ventilating people. Here is your, I'm going to screen share again. Here's your bag valve mask again. Okay? Here it is. But using a bag valve mask is actually pretty difficult. It's hard to keep a good seal. The mask has to be sealed to the patient's face. It's hard to do that at the same time you're squeezing the bag. You're going to come to know that's true because we're going to train a lot on using a bag valve mask. But the National Registry says the data would suggest it's easier for resources that are limited to give ventilations with a mask to mouth technique. Okay? You could take the mask off and just use your breath with the mask. Because as you can see from this young lady here, You can use all of your hands to seal the mask to the patient's face. It's easier to do that. It has a one-way valve on it, so you can't get any blood or vomit or nastiness inside of you. There's a filter in there, so if there's any bacteria or viruses coming out of them, you're not going to get it. And you can normally hook oxygen up to these face masks. You're going to see a lot of questions about using the mouth-to-mask technique. You need to know that the mouth-to-mask technique is approved. It is very useful. Arguably, people with limited experience with bag valve masks are more successful at using a mouth-to-mask technique than they are a bag valve mask technique. The way you oxygenate the mouth-to-mask technique is two options. Either the mask has a port to plug oxygen to it, or you put a nasal cannula on yourself and turn it up to 6 liters per minute. Yeah, I said it. It's funny, but it's true. The National Registry wants you to know that if you were using a mouth-to-mask technique and the mask didn't have a way to oxygenate the mask, you would put nasal cannula oxygen on yourself and turn it up to 6 liters per minute. Now, here's where I think it gets a little stupid. Why wouldn't you just put the nasal cannula on the patient and turn it up to 6 and then put the mask on top of the cannula? There's no reason why a patient can't have a nasal cannula underneath this mask. So, if this was your patient, if you went to an overdose, the patient's not breathing, there's no chest rise and fall, you have a mouth-to-mask technique option. You don't have a bag valve mask. What I would suggest you do is put in an OPA, an oropharyngeal airway. That will keep the airway open. Put a nasal cannula on the patient's nose, right? Put it in their nose. Turn it up to 6 or maybe 15. Don't tell anyone I told you that. Turn it up and then breathe for the patient with the mouth-to-mask technique. Now, none of this works if you don't have an open airway. So I would argue that if you are ventilating a patient, you have got to have an adjunct in place. We don't tend to ventilate patients who are conscious. There are a few times where we do. That is not very common. It has gone away because we now have better technology. You're going to learn about that later. Nowadays, if someone's being ventilated, they're only being ventilated because they are unconscious and they probably have very low tidal volume and a very low breathing rate. That's why we would be ventilating them. I would argue that if you are ventilating a patient, you must have an OPA in place or an NPA in place because you can't get air into the lungs with a bag valve mask or a mouth-to-mask technique if you don't have an open airway. Never use a bag valve mask. Never use a mouth-to-mask technique without an OPA or an NPA, whichever one is indicated. You've got to always maintain the airway open. Let me tell you another reason why patients who aren't breathing well, we can do a lot for them with oxygen in regards to if their airway is open. There is something called apneic oxygenation. Okay? Apneic oxygenation. I'm just writing that so you can see what I'm saying. Can anyone remind me again what apnea means? They're not breathing at all. Did you know that your lungs, your alveoli, will take up oxygen whether you're breathing or not. Because they don't take up the oxygen because you're breathing. They take up the oxygen just because it's present. It's either there or it's not there. Ventilating just happens to be the way that we get the oxygen there. But if you weren't breathing and the oxygen kept coming there anyways, you would use it. You would oxygenate just fine. We proved this in the operating room by sedating and paralyzing patients and then not breathing for them upwards of 60 minutes, an hour. There is data in an Australia operating room with a patient who has an OPA placed with a nasal cannula turned up to 15 liters per minute, and the patient maintained SpO2 saturation of greater than 94% for up to 60 minutes without a single ventilation. That's called apneic oxygenation. It's the understanding that we do not respirate by simply ventilating. We respirate because oxygen is readily available at the alveoli. It either is or it isn't. Normally, the way it is available is because we ventilated it there. But if you didn't ventilate it there, and it was still present in a very high concentration, you would use it. Because ventilation is separate from oxygenation. Ventilation is not the same as respiration. Ventilation is the movement of air in and out of our lungs and in and out of our alveoli. Respiration is the actual uptake of oxygen and the release of carbon dioxide by the process of diffusion. Diffusion does not require work. If the gas is present, it will simply occur. So then, I stretch you to this. If we know that is true, and a patient is in trouble, we should keep their airway open and give them high flow O2 because the oxygen will get to the right spot. If we're going to go to intubate a patient who's not doing well, let's say we have a patient who is in respiratory failure. They have been breathing tachypnic for 30 minutes. They have been super labored. They are very tired. It's not working. When we got there, their SpO2 was 80% on room air. We put them on a non-rebreather at 15 liters per minute, and the patient only improves to 85%. Why? Because they can't get the oxygen to the alveoli. Their breathing is no longer effective. They're breathing at 40 times a minute, but it isn't getting the oxygen down to the alveoli. That is the definition of respiratory failure. So we're going to intubate that patient. Wouldn't it be smart to throw a nasal cannula on the patient and turn it up to 15 liters per minute and maintain the patient's airway open while we sedate them and we give them a paralytic that stops their breathing? If we didn't do apneic oxygenation, they would lose so much oxygen so fast because we stopped what breathing they do have that they would probably go into a cardiac arrest before we could get the breathing tube in the trachea. So how do we bridge the gap between an awake patient who needs to go to night-night so we can breathe for them and the fact that if we stop their breathing, they'll die? The answer is apneic oxygenation bridges that gap. The whole point of this conversation is for you to understand the success of oxygenation with an open airway. You can get oxygen to the right place if you're flowing it at a high enough rate simply because the airway is open. So I encourage you with patients who are in distress to use all of the tools in your toolbox. It is not uncommon for us to put a nasal cannula underneath a non-rebreather mask and turn it up to 6 and then have the non-rebreather on at 15. It's not uncommon for us when we go to intubate patients to put a nasal cannula on the patient underneath a bag valve mask and turn it up to 15 liters per minute. The reason is we want to oxygenate the alveoli as much as possible to turn the patient around, to fix them. That is the topic of apneic oxygenation and why we would do it. So Zach says something very important. Well, sure, Justin, you can apneic oxygenate a patient, but they're not getting the CO2 out. Isn't that bad? And the answer is yes. Yes, that is bad. But what's worse? Now, Zach, would we consciously every day apneic oxygenate a patient to the 60-minute mark? Hell no. We have no reason to do that. So the answer for you is this is just a short amount of time to bridge the gap between us taking over the patient's breathing and them not breathing for themselves. If we wouldn't bridge that gap, they would probably just immediately go into cardiac arrest and we would have a bigger fight on our hands. So apneic oxygenation's to bridge the gap. We are going to fix them by putting the breathing tube in, and then we will get that CO2 out. And so for whatever CO2 was trapped because of apneic oxygenation, we're going to get it out. So it's not going to make a difference. If you were to leave that in a sick patient, then yes, they would become acidotic and they would get very sick very fast, and it would take a long time to fix them. So you're right. You do need both. You cannot not have ventilation, but you cannot have it longer than we think. You can go without ventilation longer than we think. You cannot go without oxygenation for very long at all. Does that make sense, Zach? Does that answer your question? Awesome. So as we go on, we'll build on this. You should know that you're going to see apneic oxygenation on every patient we intubate. You should see. I'm telling you what you should see. If your provider is a good provider, if your paramedic that you're working with is a good paramedic, if the EMT that you're working with is a good EMT and they're about to put a supraglottic airway down the patient's throat, why wouldn't you apneic oxygenate the patient? Why wouldn't you give those alveoli the best chance they have at maintaining a high concentration of oxygen while we're doing these procedures that take a little time? It takes time to put down a supraglottic airway, a king tube. It takes time to intubate the patient. You can keep oxygenation levels high while you're doing those techniques, provided that you hold the airway open and you have a nasal cannula on the patient's face at a high flow rate. Are there any questions about how to use, let's go with why to use nasal cannulas, why to use non-rebreathers, why to use bag valve masks, when you can use them together, when you can use an NPA versus an OPA, a head tilt chin lift versus a jaw thrust. Any questions about any of this? I want to remind you that you can use these things together. I always say, if one nasopharyngeal airway is good, then two has got to be better. Let's say that we're going to go ventilate a patient who's 450 pounds and they have no neck. that's going to be a really difficult patient to ventilate. It's going to be really hard to keep that airway open while you're giving those breaths with a bag valve mask. So then why wouldn't you use all of the adjuncts? Why can't you use an OPA and 2 NPAs, or maybe an OPA and 1 NPA? There's no rule that says the airway's too open. That doesn't exist. So I want to remind you that airway management is difficult. It is difficult to get people to breathe who aren't breathing on their own. It's actually one of the most difficult things we do, and is one of the most important skills for us to refine and master. So I want to remind you that these solutions can overflow, and they can work together. If one is good, two has got to be better. Now, they have to be indicated, and they have to not be contraindicated. So you can't go using an oropharyngeal airway on someone with a gag. You can't do that. But you could use 2 NPAs on a person who just had a seizure and is not coming around. They're so unconscious that their tongue is touching the back of their throat, but they have a gag. So then put in a couple NPAs and put them on a non-rebreather mask. Put in a couple NPAs, suction the nose and mouth if you can, and put them on a nasal cannula and a non-rebreather mask. The point is, do whatever we need to do with the tools that I've just given you, opening it, clearing it, oxygenating it, ventilating it, whatever is indicated. Use all of these tools and use them as much as you need to and together if you need to get the patient oxygenated. When you start talking about seizures, when you start talking about strokes, when you start talking about people who go unconscious, you've got to get the airway open and you've got to get the oxygen down to the alveoli. We said that the alveoli live in the most bottom and lateral spaces of the lungs, the inferior and lateral spaces of the lungs. Only about 20% of lung space has oxygenating capability. If you aren't getting that chest rise and fall, you are not going to oxygenate the patient, period. So my advice to you is use as much of these tools as are necessary to get chest rise and fall, to get the oxygen to where you know it needs to be. We know that we have an SpO2 monitor, the little finger ditty. Put the finger ditty on. And if you've got a good graph on the finger ditty and it's showing 80, then you've got to oxygenate them. Maybe you got to ventilate them until you get to a number that's greater than 94%. This is how we open and clear airways. This is how we oxygenate and ventilate patients who are not oxygenating and ventilating well enough on their own. You're going to see a lot of questions that ask you whether you understand if the patient is breathing okay on their own or if you should breathe for them. Here is the trick. Labored equals oxygenate. Shallow equals ventilate. Even more so, it goes to the idea that a patient is not breathing effectively if their breathing rate is low or extremely high, and they are unconscious or of a low consciousness. That's what you're going to look for in the test questions, and more importantly, that's what you're going to look for in real life. If the patient isn't very conscious, I'm worried if they're breathing well on their own. Should I be breathing for them? If the patient's breathing rate is less than 8, I should probably ventilate. And that rhymes. Less than 8, ventilate. It doesn't mean that every single patient whose breathing rate is less than 8 will need to be ventilated. That's not true. But it is a good way to remind ourselves that people who are breathing at a rate of less than 8 typically are not oxygenating enough. They don't have enough minute volume. If you're looking at the fact that minute volume should be 6 to 8 liters per minute, if a person is breathing 6 times a minute at 400 cc's, that puts you at 2.4 liters. Nobody is supposed to be breathing at 2.4 liters. So if you learn minute volume, like we have said you have to, you'll understand that you need 6 to 8. If you start doing the math, anything less than 8 typically doesn't work. You would put the appropriate company. What's the rate? What's the rhythm? What's the quality? What is the patient's consciousness? If you add that up, it's low consciousness and low breathing rate and low chest rise and fall, then you should be ventilating that patient yourself. If the patient is conscious, they do have good chest rise and fall, but they're just working hard to breathe, then oxygenate the patient with a non-rebreather mask. By the time you're done with this lecture and by the time you're done with this chapter in your studying, you need to be able to say whether a patient should be oxygenated or if they're so far gone that they should be ventilated. You need to be fluently able to decide whether a head tilt chin lift will work or do you need a jaw thrust. You need to be fluent in an oropharyngeal airway being the choice because the patient doesn't have a gag. Or the patient's low in consciousness but they have a gag, so then I'm going to go with a nasopharyngeal airway. You need to be able to move these things around and understand why one is the good choice and the other maybe not. You also need to know that you can use these things together for patients that are indicated for such. Remember that indication means why we do something, and contraindication means why we would not do something. So for every single tool that we use, there will be indications of why we should do it. And then there will be contraindications in patients that say, don't do that to them for this reason. One of the contraindications that I forgot to mention for nasopharyngeal airway is facial trauma. If the patient has a bunch of broken facial bones, we worry that the nasopharyngeal airway, the NPA, could go into the brain, which is kind of funny. And there aren't a lot of cases of that, but there are some. And if you guys remind me, I have a picture of a CT image post-mortem where the nasopharyngeal airway went into the brain space instead of going down the back of the nasopharynx and keeping the tongue off of the hypopharynx. So I can show you that. So the indication to an airway adjunct is low consciousness, not having an open airway. The contraindication to an OPA is that they have a gag. A contraindication to a nasopharyngeal airway is that their face is so broken, they have so much facial trauma, head trauma, skull trauma, not just that they hit their head, not that they had a stroke, but that you feel their physical bones and they feel unstable. You wouldn't put an an NPA, a nasopharyngeal airway, in that patient because you got to wonder where it'll go. The reason it follows the nasal canal is because the nasal canal is lined by bones. And if those bones are broken, then you can't be sure where the airway will go. Any questions? Raise your hands if you feel like you're drowning. No one's going to speak up. All right, raise your hands if you're ready for a break. Good, very good. All right, let's take a break. We'll come back at 10:20.
You are now muted.
back on. I'm going to refresh my screen, so I'm going to pop out and pop back in. All right. All right. Raise your hand if you can hear me and you're ready to go. Let's see who's not with us and ready to go. Braxton. Alec. Alec's on here only, so maybe that's what his little deal is. Braxton, you still here? You've had to log in and out, so I think you're having connection issues. All right, let's continue. By the way, this slide, I think, is your first time meeting Gloria. Gloria and her husband, Bob, I don't know if that's their real names, but they just feel like Gloria and Bob to me. They will follow us throughout the whole book. I don't know how much they paid Gloria and Bob, but they must have did it enough because they're in every picture. Not everyone, but they're throughout the book. So that's Gloria. She's here with us. All right, let's keep moving on. See if we missed anything here. It is a test question. How much air do you give with a BVM, a bag valve mask? And does anyone know the answer? How much air do you give with a BVM? How much squeeze? When do you stop squeezing? Anybody? When you see chest rise and fall. We don't overventilate patients. When you see chest rise and fall, you stop squeezing the bag. That's a test question. When do you stop squeezing the bag? They'll probably word it like, when do you know you've given enough breath? Or how much air do you deliver with a BVM? The answer is until I get chest rise. Okay? Every breath you deliver must get chest rise in the patient, or that breath likely didn't go in or it went to the stomach. Okay? Let's talk about that conversation for a second, okay? We're going to talk about breathing for people with a bag valve mask. We've talked about breathing for people with a mouth to mask technique. We breathe for people one breath every 5 to 6 seconds. So you literally count to 5, or more importantly, 6, and then you squeeze the bag. Or you count to 6 and you give a breath from your own breath with oxygen on your mouth to mouth technique. So one breath every 5 to 6 seconds is the rate we're going to breathe for people. And we're going to squeeze the bag or give that breath until we see chest rise and fall from the patient. But we've discussed that it's difficult to use positive pressure ventilation. By the way, anytime you're using a BVM, it's called positive pressure ventilation. You might see test questions that say you're using PPV. Well, you need to know what using PPV means. Positive pressure ventilation. So anytime that you're using PPV, you need to realize that it's difficult. And that if you don't get it right, all of that air goes into the stomach and not into the lungs. What does gastric inflation cause? The answer is death. It causes death. For every amount of air you put in the belly, you're very likely to get vomit back, and that makes an aspiration risk, right? Well, let's take that even further. If you keep ventilating the patient's belly and not their lungs, let's say that every time you squeeze the bag, you gave 400 cc's of air. Let's say 400 cc's of air went to the belly, and you're doing that one breath every 5 to 6 seconds. So now you've done it 12 times. Well, now you've done it 10 times. There's 4 liters of air in the patient's belly and not in their lungs. That's going to push the stomach up against the lungs and the heart and smash it into the top of the chest. And guess how effective their mechanical actions will be after that? The lungs have to physically be able to move in the chest. The heart has to physically be able to move in the chest. If you inflate the stomach so much that it smashes the heart and lungs up into the chest cavity, they cannot do their mechanical jobs and the patient will die. Gastric inflation causes death. Gastric inflation causes the patient to vomit and then aspirate that vomit into their lungs, and then they die. So, you've got to understand that when you give patients BVM ventilations, positive pressure ventilations with a bag valve mask, that the tube it wants to go into is the esophagus, not the trachea. How do you coax that air into going into the trachea instead of the belly? The answer is maintaining a good seal with the mouth to mask technique or a bag valve mask to face technique and an open airway. If you attempt to ventilate a patient whose airway is not fully open, you will push that air into the belly, not the lungs. You must use an adjunct when you're ventilating patients to keep the airway open. Air and fluid, gas, takes the path of least resistance. The path of least resistance is the belly. The esophagus is straight shot to the belly. It takes curving the air upwards to get it into the lungs, which is not the path of least resistance. What am I telling you? It takes time and skill to learn how to effectively ventilate a patient with a bag valve mask. A lot of people think they can do it, and a lot of people suck at it. A lot of people put air into bellies. In fact, it is a required skill that when we get to a patient, a paramedic does, and intubates the patient, the next thing they should do is put down an orogastric tube to get the air we know will likely be in the belly out of the belly. I'm telling you that we know this happens so often that we are required to put a tube into the stomach to get that air out once we get an established airway. You've got to be sure when you squeeze that bag that it resulted in chest rise. If it didn't, you got to know that air went to the belly. And every time you do that, you're increasing the chance the patient's going to die and not live. You must understand that a bag valve mask is a weapon. It is a weapon to deploy appropriately and effectively and with high level of skill, or it does more bad than it ever does good. Let me tell you what else positive pressure ventilation does. Let's say that you are getting all of your air into the lungs and not into the belly, but you're going too fast and too hard. Say you're supposed to be breathing one breath every 5 to 6 seconds, but you're really nervous. So you're breathing one breath every 2 seconds. How often do we look up at the person at Airway and they're just squeezing that bag, squeezing that bag, squeezing that bag? You're not letting the lungs deflate. The breath should go in, and then there should be enough time allowed for the breath to come out. If you keep breathing that air in, breathing that air in, breathing that air in, their lungs are holding on to that air. Underneath those lungs are the great vessels. Specifically speaking, the vena cava. The vena cava's job is to return blood to the heart. You do not get out of the heart what you didn't put in it. If you keep inflating those lungs and they're sitting there like big old balloons pushing against that vena cava, you are reducing blood return to the heart and thereby reducing the blood that the heart puts out. Their blood pressure will go down. That means their shock level will go up. Their oxygen level goes down. Their death chances go up. Everything that you can get wrong on a BVM will kill the patient. Whether that means you're overventilating, you're breathing too fast, you're giving that breath too hard, or you're not even ventilating the lungs at all, you're ventilating the belly. You are killing the patient, not saving the patient. Most people wielding a BVM are wielding it incorrectly. That's not my opinion. That's what the data says. In fact, Zoll the company that makes the cardiac monitor, knows this to be so true, they went out and invented a device that they can put on the end of your BVM. All brand new Zoll monitors come with this device that will measure the actual volume of breath you just gave so that you don't overbreathe the patient, so that you don't breathe the belly and not the lungs. This is a big problem. You have got to remember, and you're going to see test questions about the fact that overventilating the lungs will squeeze the vena cava closed and it will not let blood go to the heart. Raise your hand if you hear me loud and clear and you understand. Are there any questions about suppression of the vena cava by overventilation? You need to remember that the heart, the lungs, and the great vessels share their real estate with one another. If you piss off one of them, it is a matter of minutes before you have pissed off all of them. You don't tend to get any free passes with anything that involves the lungs, the heart, and the great vessels. They're right there in the same space. So if you overdo something with one versus the other, the one that you didn't do it to will still have an impact. You overventilate the lungs, you close the great vessels. You overventilate the lungs, you don't get the air into the lungs, it goes into the belly. Now you're pushing all of the organs in the chest up and smashing them to an extent that doesn't allow them to do their job. You need to remember that we ventilate physiologically via negative pressure. That's a test question. How do humans physiologically breathe? And the answer is via negative chest pressure. That's our system. We, the provider, give artificial ventilation via positive pressure. That's not how you normally breathe. And so then it has additional costs. You need to know the costs. You need to know why positive pressure ventilation is a good thing that quickly becomes a bad thing. If you do not wield this weapon correctly, effectively, efficiently, a skill that you have mastered, you are hurting your patient. You are not helping your patient. Okay? I hope I've been clear on the limitations and the problems with positive pressure ventilation. You're going to read it. There's another bag valve mask. Let's move on. You are going to see transport ventilators, but you guys aren't typically going to be managing transport ventilators, but you can't. Okay, Zach. So to prevent ventilating the belly, make sure airway is open. Yes. To prevent overventilating the lungs, maintain a rate of 1 breath every 5 to 6 seconds. Yes. And only squeeze the bag enough to cause chest rise. You can overventilate by breathing too many times, and you can overventilate by breathing too much air in each breath. Remember that the lungs will only take 4 to 6 cc's per kg of breath, sometimes up to 8 cc's per kg of breath. Everything after that has got to go somewhere else. And where is that somewhere else? The belly. So let's say the patient's being kind to you and they're going to take 8 cc's per kg. That's 800 cc's of volume maximum. Well, guess how much a normal adult BVM bag valve mask can do? Somewhere between 12 and 1600 cc's. On the short side, that's 400 cc's extra. On the high side, that's 600 to 800 cc's extra. So potentially, if you're overventilating the patient, you're putting 400 to 800 cc's of extra volume in the belly every single breath. So the answer is, you got to have an open and patent airway. So use an adjunct. Don't overbreathe. 1 breath every 5 to 6 seconds. And do not breathe too much. Only give that breath enough to cause the chest to rise and then stop squeezing. Okay? For automatic ventilators, if the patient is on a ventilator already and they're doing well, it's not failing, you can transport that patient as a BLS provider. If it were to fail, it's no longer appropriate. It's not ventilating the patient. Their SpO2 is low. They're looking poor. They're starting to be in more distress. Take the ventilator off and bag the patient. BVM ventilations. Never forget that If technology is failing you, go to the basics. If this Mac Daddy $30,000 ventilator is failing, take it off and go to the basics. Grab a BVM and hook that BVM up to their trachea, whether they've got a tracheostomy, whether they've got an endotracheal tube, whether they've got a supraglottic airway, and breathe with a BVM. Never underestimate the power of the basics. Don't fight with a piece of technology that you don't understand. Okie dokie. All right. Let's dig a little bit. Let's get a little deeper. Okay? Let's go back to B. Let's go back to breathing. I told you, let's talk only about conscious patients. Let's talk only about patients who are breathing on their own with good tidal volume. Remember that tidal volume equals chest rise. So right now we're talking about a conscious patient. We're talking about a patient who's spontaneously breathing. We're talking about a patient who is in distress, but not in failure. Distress looks like tachypnea. Distress looks like tripod position. Distress looks like 2 to 3 word dyspnea. Distress looks like labored breathing. That's who we're talking about right now. Caitlin, you got a question? Okay. That's what distress looks like. All right. I'm going to give you a scenario. We're going to talk about a patient who should have called 911 3 hours ago. Okay? Think about that. Here's a person who's been having trouble breathing for multiple hours. You should call 911 the moment you have trouble breathing, right? But let's say, for whatever reason, the patient waited. They didn't call 911 for 3 hours of having labored breathing, trouble speaking in full sentences, looking cyanotic in the lips, blue in the lips. Their skin's pale, they're clammy, they're clearly struggling to breathe here. Fast breathing, labored. They don't call for 3 hours. By the time we get there, the muscles that help you breathe, the intercostal muscles, the ones between your ribs, the peristernal muscles, the ones around your sternum, the subclavicular chest muscles, the ones below your clavicle, those muscles are why you breathe. They're why your chest expands. Well, now it's been 3 hours, so you're very tired. So we get there, and Justin said, if the patient looks labored, put them on oxygen. If the patient looks in distress, put them on oxygen. If the patient has 2 to 3 word dyspnea, put them on oxygen. That's what I said. So you do. You take out your non-rebreather, you turn it up to 15 liters per minute, and you put it on the patient's face. And the initial SpO2 you got on room air with no oxygen, 21% oxygen in the room, was 80%. You were like, whoa, that's bad. So you put them on oxygen. And 10 minutes later, they're 85%. Now, they're still conscious. They're still good chest rise and fall. They're still breathing effectively on their own, but very labored, very tired. All that oxygen that we gave them isn't going down the chute. When you get tired, you don't have the ability to get that oxygen to that 20% we talked about that oxygenates the lungs. You can move air up and down the lungs all you want, but if you don't get the air to the alveoli, you will not benefit from that oxygen. So here you have put them on 95% FiO2, and you're thinking to yourself, I'm giving you all this oxygen, why isn't it working? The answer is they're too tired to get the oxygen to the good spot. What if you could take a little non-rebreather and put some pressure behind it? What if you could force that high concentration of oxygen down to the alveoli? How much better would they then get that oxygen and release that carbon dioxide? And that is what CPAP is. continuous positive airway pressure. You need to memorize that acronym, and you need to think of CPAP as nothing more than a non-rebreather with a little machine that's pushing the oxygen. Instead of the patient having to spontaneously breathe in the oxygen, now we have a machine that's forcing that oxygen down to the alveoli and saying, take it. CPAP could not be underestimated as a great tool in the toolbox of EMTs and paramedics. Here's how to deploy it. If the patient is still conscious, if the patient is still getting good chest rise and fall, but you put them on high flow oxygen and they're not improving their SpO2, it's time to move the patient to pressure support. You need to support the oxygen that you're giving them. You need to force it into the good spaces. That is CPAP. CPAP is nothing more than when you go to exhale, there is a little bit of force keeping the alveoli open and not letting them collapse on themselves. I told you in the anatomy chapter that alveoli are lazy. Those little air-filled sacs all the way down in the bottom and sides of your lungs, all the way down there. They're lazy. And so if they're tired, the moment you exhale, because you've been waiting, you waited 3 hours. You waited 3 hours to call 911. Now everybody's tired. The lungs are tired. The intercostals are tired. The peristernal muscles are tired. You're tired. So now those lazy alveoli just collapse on themselves. There is no diffusion. There is no taking up oxygen. There's no respiration with a collapsed alveoli. CPAP will hold them open. CPAP is a mask that goes over the patient's nose and mouth. This version that you're seeing on the screen here, that's for people who have sleep apnea. That's not the kind that we use. It looks the same, except the mask goes over the nose and the mouth. And it gives force to the good oxygen that you're giving the patient. And now, as they weren't before because they were tired, with CPAP, we can get that oxygen to the alveoli. Do you have any questions about the concept of continuous positive airway pressure? Yes, this is a BLS skill. I would encourage you to go to YouTube and put in EMS CPAP and witness a couple of these devices being put on the patient. It's very simple technology. It's made out to be a very difficult technology. It's not. It's in the BLS scope, and you can use it to better your patients. So the settings, if you didn't know, right now you have CPAP in your body. Physiological PEEP is at about 5 centimeters of water. Everyone in this room that you're in right now, everyone in this room that I'm in right now has physiological CPAP, which we also call PEEP. PEEP is peak end expiratory pressure. You need to know that. CPAP is PEEP. PEEP is just the amount of pressure in your lungs that you have when you have exhaled that keep the alveoli open. Imagine if the scenario I just talked about happened every time you exhaled. Imagine if every time you exhaled, the alveoli collapsed on themselves. They would never be ready to receive the oxygen from the next breath, and you would die. So physiologically, we're all sitting in here with about 5 centimeters of water. PEEP. PEEP is CPAP. Well, we can increase it. We can increase the number. We can add 5. We can add 7. We can add 10. Those are typical settings of CPAP. Justin, put the patient on CPAP at 5. Okay, I'm going to put the patient on CPAP at 5. So the oxygen's turned up to 15 liters per minute, or however much we want, maybe 100% FiO2, and we add 5 more pressure. to the patient's normal PEEP. We add 7 more to the patient's normal PEEP. Maybe we add even 10 more to the patient's physiological PEEP, so that those alveoli don't collapse and that breath that they just took gets the oxygen to the good space. So if I ask you, what are your CPAP setting options? The answer would be 5, 7, and 10. Justin, I could put the patient on 5 centimeters of water of CPAP. I could put the patient on 7 centimeters of water of CPAP. I could put the patient on 10 centimeters of water of CPAP. I want you to think about CPAP as nothing more than a non-rebreather mask on steroids. It's a non-rebreather mask with pressure behind it. Any question about CPAP? I do not think that you will see a lot of questions about CPAP on the National Registry. I don't have a single student who's come back to me and said CPAP was on the National Registry. If you see it, please call me and tell me, but I have not seen it thus far. It could be on the National Registry, but I have never seen them put it on there. Here's why. The National Registry leaves it up to the state whether you are good enough as EMTs to use CPAP. I think strongly and confidently that you are, but they're not sure. So they talk about it, but they don't really go far into it because they're not sure if you should do it. Well, in the state of South Carolina, we have decided in our law that you are capable of doing CPAP and that you should. So you need to know about CPAP. We're going to learn later who best benefits from CPAP. There are conditions, there are diagnoses of patient populations who do best with CPAP, who CPAP will turn around. That is the go-to treatment for them to make them better. We're going to learn that later. Right now, I want you to dive into what is CPAP. And so let's talk about an algorithm I want you to adopt in your head. If the patient is conscious, if the patient is labored and breathing, start with a non-rebreather. If the non-rebreather doesn't start working very quickly, move to CPAP. Boom, there you go. That's it. Non-rebreather, CPAP. If CPAP fails you and the patient no longer has good rate and volume, their chest rise and fall is bad, their rate is bad, their consciousness is going down, then you would move to positive pressure ventilation, right? That's your algorithm. You have the options between high flow oxygenation with CPAP, and then positive pressure ventilation. That is your airway management. Any questions? Raise your hands if you're still alive. Beautiful. Beautiful. All right, hands down, let's keep moving. Make sure you memorize what CPAP is, and make sure you memorize that these are your settings, okay? Oh, look, I know you're not raising the hand on purpose. Poor thing's probably trying to learn how to use the computer. I'm just kidding. All right, so I want to remind you, CPAP increases the pressure in the lungs, just like positive pressure did. If you overdo it, you reduce the blood flow return to the heart. So you wouldn't use CPAP on people that don't have good blood pressures. You would not use CPAP on people who aren't conscious. You would not use CPAP on people who are not breathing with good enough tidal volume for the CPAP to work. They've got to be breathing on their own. They've got to have spontaneous breathing. The CPAP supports their breathing. So don't use this on people who don't have good blood pressures, because CPAP reduces blood pressure by reducing the blood flow through the vena cava. It's going to put pressure on the vena cava, and it's going to close it a little bit. And so if it closes it a little bit, you're not getting much blood back to the heart. And if you don't get much blood back to the heart, you're not getting much blood out of the heart. And that would reduce blood pressure. So don't use it on people with low blood pressure. Don't use it on people who are not conscious. Don't use it on people who don't have lungs that are intact and whole. As in, if they have a pneumothorax. If one of their lungs is popped and you give them CPAP, you're going to increase the problem, and very quickly. So, you need to know the indications of CPAP and the contraindications of CPAP. Who I would use it on, who I would not use it on. let's move forward. All right, we already talked about the settings. All right, here's all your stoma talk. I'm going to let you look at that. I want to remind you also to dig deep into the difference between ventilation and respiration in this chapter. Remember, you're going to see a test question that says, air is moving across the alveoli. Is that ventilation or respiration? And a lot of you like to choose respiration because they said alveoli. And you know in your head that that respiration takes place at the alveoli. Well, yes, it does. But so does ventilation. You've got to pay attention to the question. If it says that you're moving air, the answer is ventilation. If it says you are changing oxygen and carbon dioxide, then that would be respiration. So if you see a test question that says air is moving across the alveoli, is that ventilation or respiration? The answer is it's ventilation. It is ventilation to move air. Okay, moving forward. We already talked a lot about tracheostomies. Here's a stoma. The only difference is one has a tube in it and one don't. No big deal. You can ventilate both. We're going to talk about what to do with airway obstruction. As far as upper airway obstruction goes, if it's stridor because of anaphylaxis, then give them epi. If it's lower airway obstruction, they're wheezing, we're going to give them albuterol. So you're going to learn about that. You don't need to know that yet. You don't need to know epi. You don't need to know albuterol yet. We're going to get there. But if it's obstruction, there's two kinds of obstruction. Physiological obstruction, which would be mucus, saliva, blood, Max Bart's car, gym clip, tuba gear, tuna steaks, steak, potatoes. Those would be physiological obstructions. You would get them out if you could. We'll learn how to get out things like food. But typically an obstruction would be the tongue. Typically an obstruction would be blood and vomit and mucus. You know how to deal with those. If it's food, then we would do the Heimlich, and you're going to learn how to do that later. Okay? So you know how to deal with an upper airway obstruction. A lower airway obstruction would be treated by medication, and we're going to learn that later. There's Bob choking. I don't think Bob's as old as Gloria, but later on he will be. We'll learn how to deal with that. You're going to see some test questions that say, do you remove dentures? If you were going to ventilate a patient with a bag valve mask, do you have to remove dentures? And the answer is, well, no, I would remove them if I had to. You're going to come to know that you need a good seal with the mask. And a good seal comes from the mandible and the maxilla. If the mandible and the maxilla and the teeth are in place, that's a good thing. It gives you a good amount of surface area to create that seal. The moment you take the teeth out of the mouth, I don't know if you've ever seen anybody without any teeth, but the mouth space is very unsupported when people don't have teeth. So if dental appliances are in place and secure, they're not moving about, they're not an obstruction hazard, leave them in place and use them to your advantage to create your seal. If they are loose and moving about and you're worried about them, then you have to take them out. You're going to be asked questions about the B magic algorithm, but it'll only be in this particular chapter. So when we talked earlier about what we are going to do to bridge the gap between a patient who needs to be intubated and a patient who's breathing on their own, well, that is B magic. B magic is how to buy yourself enough time to put in your king tube. How to buy enough time for Justin to intubate the patient without the patient going into cardiac arrest. If you want to prevent a patient from going into cardiac arrest who we need to put in a breathing tube for, then you would go through the B magic algorithm. Ventilate the patient with a bag valve mask to pre-oxygenate them. Make sure that the airway is such that we can ventilate and put in the airway tube. Make sure we can do a jaw thrust. We can do a head tilt chin lift. Manually manipulate the airway. Try to get the tube into place the first time, whether that's your king tube or my intubation tube. Try to get it in there the first time. If we can't, immediately go to a supraglottic airway if you aren't able to get the endotracheal tube in. And then once we place any type of those tubes, we need to monitor them to make sure they stay in the right place, that they are giving oxygen to the lungs and they are receiving carbon dioxide out of the lungs, which we do by monitoring carbon dioxide. C, confirmation, is talking about entitled CO2, which we learned in our vitals lab last week. It should be 35 to 45 in metric value and a square waveform. That's how you'll monitor breathing tubes to make sure that they are giving air to the lungs and getting carbon dioxide out of the lungs. B magic. Pre-oxygenate with a BVM. Look to make sure we're going to be able to do this. Evaluate for difficulty. Manually position them. Get the tube in. Go to a supraglottic if you can't get the first tube in, which would be a paramedic skill, right? And then whether you got the first one or the second one, you need to keep a confirmation on that tube, which is entitled CO2. Any questions about B magic? All right. There are tons of versions of B magic. There are tons of versions of checklists. There are tons of versions of algorithms that we have in order to not fail airways. When I say fail an airway, I mean we put a patient to sleep and then we can't breathe for them. That would be a failed airway. The patient would die. It's a big deal, right? I mean, doesn't that make clear sense? It's a big damn deal. If you're going to put a patient to sleep because they're not breathing well on their own, you've got to be able to breathe for them. So the B magic algorithm exists in multiple different ways, and the only point is so that we do not put people to sleep and then not be able to breathe for them. I remind you that putting people to sleep and putting in tracheal intubation, putting in a breathing tube in their trachea, is a paramedic skill. However, you are a very high-performing and, depending on your success, make or break to the skill. Yes, it's controlled by a paramedic. Yes, it's a paramedic thing. But you are an integral part in whether it works or not. And if I can't get my tube in place, you've got to get your tube in place, or I've got to use your tube to get it in place. One of those breathing tubes has to be put in the patient, and we have to get it to work, and we have to start breathing for them, or they will die, because we gave them a medication that prevents them from breathing on their own. So make sure you understand what it means to put a patient to sleep and get a breathing tube in them so that we can breathe for them. That's what we have to do when patients are in respiratory failure, when they have gone beyond distress. They've gone beyond 2 to 3 word dyspnea. They've gone beyond tripod position. They've gone beyond low SpO2 and cyanosis in the lips, blue lips. They're beyond that. Now, their mindsets, their mentation, their consciousness is declining. They're no longer talking to us. They're no longer able to follow our commands. And then they stop having good chest rise and fall. That's the difference between distress and failure. And that is what your discussion post is on this week. I want you to be able to see the difference in that. Okay? Question number 1. Breathing is controlled by an area in the brain called the what? This is straight from the anatomy that you should have learned in Module 1. Where do we learn to breathe from? Who's controlling that? The brain stem. Specifically speaking, the medulla oblongata and the pons. The brain stem controls our breathing. The EMT should assess a patient's tidal volume, which we know to be equivalent to chest rise, by what? Observing for chest rise. In an otherwise healthy individual, the primary stimulus to breathe, we specifically talked about this last week. Why do we breathe? And we said it was unique, that it's not what people think. Yes, Rachel, very good. Yes, Tori, very good. Clayton, very good. We breathe because the level of carbon dioxide, which is bad. Carbon dioxide's bad. It increases to a point that the body says, oh, this is bad. I got to get this off. I got to get it out. And that is why we breathe. We want to breathe out that carbon dioxide. Carbon dioxide is acid, and we don't want to become acidotic. Humans are typically very in the middle of the road. Our pH is 7.35 to 7.45. Anything 7 or above is considered to be in a buffer. They're considered to be not necessarily acidic and not necessarily basic, right? We want to constantly maintain that 7.35, 7.45 environment. If you were to hold on to that carbon dioxide, you would become lower on the 7, and that is deadly. Acidosis is deadly. So that is why we breathe out that carbon dioxide. Our reason to breathe is to get off that carbon dioxide and maintain our acid-base balance. Signs of adequate breathing in the adult include all of the following except. So this is a person who looks good except this one. Shallow chest rise means we should be breathing for them. Shallow equals ventilate, and so then that's bad. The rest of these look great. Shallow chest rise is horrible. During insertion of an OPA, an oropharyngeal airway, into an unconscious patient, the patient began vomiting. What should you do first? Yeah, get them on their side. You're not going to be able to suction fast enough. Get the patient into recovery, then suction. In which of the following patients would a nasopharyngeal airway not be a good idea? C is the only one that talks about the one we're worried about. If you fall from 20 feet and hit your head, it is likely you broke something. And I don't want to go putting a nose tube in you that won't follow the normal track of the nose, because then it might go into the brain. If you go breaking the bones behind the nasopharynx, I got to worry that that tube will go in the wrong place. You are delivering oxygen to a patient with a nasal cannula at 4 liters per minute when he complains of a burning sensation in his nose. So I didn't necessarily address this, but let's see if you can use good common sense. Yeah, here's the deal, guys. That oxygen that you're putting in their nose, when you normally breathe the air in the ambient room, you warm it, you wet it, you clean it. And so by the time it goes to the back of your throat, it doesn't hurt. But we're getting it from a cold, closed oxygen cylinder. It burns. They don't like it. So what could you do to make nasal cannula oxygen better? Well, you could warm it, you could wet it, you could sterilize it. It's already sterile, so warming and wetting nasal cannula oxygen will always make the patient feel better. Now, do you need this in the short-term environment? No. You don't need this in the hours of time. But if a patient were complaining of 4 liters per minute burning their nose and you didn't have the ability to humidify, you didn't have the ability to warm it, then maybe you switch them to a non-rebreather at 10 liters, 12 liters, right? Because then it wouldn't be blowing directly into their nose. This can get so bad that it causes their nose to crack and bleed, guys. So you got to pay attention to that. Now, that does not happen in the short term. If you're talking a 30-minute transport, it doesn't happen in that short term. We're talking about taking a patient an hour, 2, 3 hours down the road. You might need to pay attention to whether that nasal cannula oxygen is going to start burning the back of their nose or not. Okay? So remember, oxygen is best given when it's wet, when it's warm, when it's sterile. A patient is found unconscious after falling from a 3rd-story window. The respirations are slow and irregular. So they're unconscious. Rate is slow. What do you think you should be doing? Yeah, we clearly have a patient whose breathing is not effective, so we should breathe for them. D. When ventilating an apneic patient, apnea means they're not breathing, with a bag valve mask, you should squeeze that bag until visible chest rise and fall is noted. You and your partner are ventilating an apneic patient when you notice the stomach is becoming distended. Distended means blowing up like a balloon. You should do what? Yeah, we know that the reason positive pressure ventilation goes bad is because your rate's too fast, your squeeze is too hard, or you don't have an open airway. So the answer to preventing or treating someone who is becoming distended is to fix your seal on your mask, fix the opening of your airway, and fix your rate and volume. So this, for that reason, is B. Come in. Or not. All right, there you go. That's the end of the airway management chapter. A lot of material that we are going to be reiterating and reinforcing and beating into you for the duration of this course. So if you feel overwhelmed, I hope you don't, but if you do, we're going to fix it and it's going to get better, and we're going to keep putting this into you. We're going to keep giving scenarios of when to do one but not the other, why you should probably do both. We're going to keep moving this around, and you're going to see the light eventually. If you don't already see the light now, I hope that you do. Okay? So dig deep into this chapter. Make sure you know the technical rules of things. Like, the book is going to give you a liter flow capability of the cannula. You got to stick to that. Even though I'm going to show you times in life where we're going to deviate from that, you've got to know the book answer. You've got to be able to spit out the foundation answer to the book. And the answer is 1 to 6. It's 1 to 6 liters per minute. Now, well, Justin, you said we could do it at 15. Well, you can, and we will. But that ain't the book answer. There's a reason for the 1 to 6. And that reason is it burns the patient's nose. So you've got to know the foundation before you can build from that foundation. When you're looking into this chapter, when you're reading this chapter, I want you to familiarize yourself with the technicalities. I want you to familiarize yourself with the rules of the game. Will we suction patients longer than 15 seconds? Well, hell yeah, we will suction patients longer than 15 seconds. We'll suction them as long as it takes to clear the airway. But that's the foundation. That's the rule. And there's a reason for the rule. The longer you suction a patient, the more you reduce their PEEP. And if you reduce PEEP, we said the alveoli will collapse. So there is a reason for the rule. These rules are important, but we have to learn that foundation before we can build from it and realize that sometimes those rules, for good reason, will be deviated from. Okay? So learn the technicality. If you run into questions, this is probably my favorite chapter and my favorite topic. If you run into trouble, come to me. We will fix it. Come in. Give me 2 seconds.
You are now muted.
Okay, I'm coming. Come, visitor. Hi, visitor. I'll be right with you.
You are now unmuted.
All right, so let's take a break so I can help one of my students, and we will come back at 11:30. Okay? I'll be back with you at, well, you know what? Let's take lunch. Let's take lunch. We'll come back at 12:15. All right, everybody? 12:15, take lunch.
You are now muted. You are now unmuted.
Clayton, I haven't even asked for the hands yet. Welcome back, everybody. Haven't even asked for the hands, and Clayton's already throwing them up. Welcome back, everybody. Show me your hands if you're here. Thank you, thank you, thank you, thank you, thank you, thank you, thank you. Thank all of you. This person is testing and not actually here, so I'll tell them they need to do an assignment. Thomas Oleg is here because he's with Jaggers, I assume. Martha's here. All right, let's get going with shock. This will be our last lecture because we will cover CPR in class this week. Again, if you can come Wednesday. If you can come Wednesday, that would be the best day to come this week. But Thursday is still available, and you'll do the same things on Thursday. I just won't get to see you do them, and that makes me nervous. So come Wednesday if you can. Let's get into Chapter 13. My screen's being recorded on both places. That one's recorded. Microphones are on. We are live. And we are here as well. I think everything the way it's supposed to be. Alright, let's move into shock. Alright, so we had to talk about Airway in order to talk about shock because 50% of what can go wrong, and I'm giving a number there. That's not a data number, but half of the equation of shock is attributed to the ventilation process. Whether an airway is open and clear, whether the ventilation is bringing oxygen down to the alveoli level and carrying carbon dioxide away. So if you can think of shock in macro scale, you would think of two things. You would think of hypoperfusion. So I want you to quickly know that that is the most current, most broad definition of what shock is. Low perfusion, all the way to the cellular level. So hypoperfusion to the farthest extent of you, to every individual life-making cell. And you would be talking about V and Q. We discussed already in the anatomy chapter, we touched a smidge when we discussed the difference between ventilation and respiration. We also hit on V and Q. And V means ventilation and Q means respiration, or globally speaking, perfusion. Anytime you get a V to Q mismatch is when people go into shock and when people eventually are irreversibly in shock. So for every ventilation, you should respirate. So then the ratio of V to Q should be 1:1. That's not a big topic. So if it immediately intimidates you, stop being intimidated by it. It's not a big topic. V is for ventilating. Q is for respirating. And for every time that you breathe in, you should respirate. You should take on oxygen and give off carbon dioxide. So it only means that every phase is working. Inspiration brings the oxygen in. Expiration brings the carbon dioxide out. It should be a ratio of 1:1. Every time you ventilate, you should respirate. This chapter is about the reasons you don't. So we're going to identify that shock is hypoperfusion, and then we're going to talk about the main reasons why a ventilation might happen, but perfusion would not. Or in reverse, while perfusion is fine, but ventilation has failed. So you should now easily see that V and Q must play together. If one plays without the other, we call that a V to Q mismatch, and that is the definition of shock. Okay? So when we talk about shock, I want you to put in your head, forever and ever, amen, that you have the V component of shock, ventilations, and then you have, to make sure respiration is occurring, the pump, pipes, fluid. We know that to be the heart as the pump, vessels as the pipes, and your blood and all that it is made of, the parts of it, to be the fluid. If you're in shock, it has to be because either V is not happening, ventilation, or one reason or another, you have failed the pump, the pipes, or the fluid. The only example where that isn't true is in the absence of oxygen, which we call hypoxia. That will be its own version of shock. You could ventilate all you wanted. You could pump all you want. You could squeeze the pipes all you want. You could have all the fluid you want, all the good stuff, the red blood cells, white blood cells, plasma, platelets. You could have it all. But if you don't have enough oxygen, it's not doing what the whole design is for. You're not sending oxygen out to every individual cell. So shock is a big idea. You can minimize the complexity of that idea by thinking about the V to Q ratio, by thinking about the fact that we breathe in oxygen, we breathe out carbon dioxide, and the pump, pipes, and fluid are going round and round to make that happen. You need to understand that the blood supply to the alveoli is so necessary, or the oxygen does not come in and carbon dioxide does not go out. Okay? Let's carry on. We already decided that. We already discussed that in that entire talk I just did. I bring you back to the flow of the blood. And remembering that blood flow returns to the heart via the vena cava. It dumps into the right atrium. The two chambers at the top of the heart are called atrium, and the right one receives blood from the body. And that makes sense because right atrium, R equals receives. R, receive. Right, receive. If you drive a boat, you already know that because red equals return, returning from. So the same is true for the right atrium. The R is returning blood. That returning blood enters the right atrium. It goes through the tricuspid valve into the right ventricle. It leaves the right ventricle and goes into the lungs and gets oxygenated because you have good perfusion. The pump is working, the pipes are working, the fluid is all present. So it oxygenates that good blood. It leaves the lungs, it comes to the left atrium because it always returns to the top. Left atrium through the bicuspid valve. You try before you buy, so that's why this on the left side is the bicuspid valve. You go into the left ventricle and you pump the blood to the rest of the body that's now oxygenated through the aorta. You've got to know that process. All right, this slide is pretty much the pump, the pipes, and the fluid. Okay, and we're going to look at the types of failure of each individual component. How can you fail the pump? How can the pipes fail you? How can the fluid fail you? We know that blood pressure is the systolic and diastolic. The systolic, the top number, which we hope is about 120, that's when the left ventricle squeezes. So it squeezes, we call that beat. Systole is another word for beat, and then the blood goes out to the rest of your body. When it relaxes, that's called diastole. That's the lower number. We hope that's around 80. And that is also, importantly, when the heart feeds itself. So systolic feeds the body and the brain and all of your good organs. Diastole feeds the heart. So systole feeds everybody else. Diastole feeds the heart. You need to know that. When you have a coronary artery, the arteries that supply blood to the heart in diastole, those are called coronary arteries. They're little tubes in and around the heart that supply the actual tissue of the heart with its oxygen. If you block one of those, that's called a heart attack. If you block one of those having a heart attack and it creates an EKG change, we call that a STEMI. So a STEMI is ST segment myocardial infarction. All that means is that you're having a type of heart attack that actually shows itself, makes itself present on an EKG, a 12 lead. In lab day, we put one of your peers on 12 lead. And then on the second day, I think we put Scott on the 12 lead. And we took a picture, the electrical picture of the heart. In diastole, if there is a problem, it will show up in the version of a STEMI or another type of heart attack called a non-STEMI. Either way, that equals a pump problem. So a heart attack would be characterized as cardiogenic shock because it affected the pump. So when you're looking at this chapter and you're looking at test questions about this chapter, they're going to try to get you to identify what kind of shock you have. The answer is, what organ did it affect? If this is a shock that affects the vessels, you have a pipe shock, then that's called distributive because the vessel's job is to distribute the blood. So this is quite easy if you think about it on a macro scale. Heart attacks are cardiogenic shock because they occurred at the pump. Let's talk about pulse pressure real quick, because you can't not talk about this and get into the medical module where we're going to talk about widening and narrowing pulse pressures. Pulse pressure is simply the top number minus the bottom number. So 120 is what we hope the top number is, and 80 is what we hope the bottom number is. So 120 minus 80 gives us 40. So pulse pressure should be 40. And we believe that pulse pressures should be greater than 25 in general, and they shouldn't change more than 10 millimeters of mercury between each other before you start having problems. So if a pulse pressure has been 40, the next one probably should be 30 to 50. It shouldn't change up or down greater than 10. And if it does, we start to find diagnoses for that. You're going to come to know that in the neuro chapter, where we look at narrowing pulse pressures. You're going to find that in widening pulse pressures. You're going to find that in the cardiac chapter, where we start looking at narrowing pulse pressures. So there are things that happen to the brain, and there are things that happen to the heart that cause pulse pressure changes. And if you're looking for them, then they're diagnostic. So the difference between the top number and the bottom number should never be less than 25. And we don't want them to move up or down greater than 10 on a general basis. Okay? The blood pressure on your left arm should be close to your right arm. Differing blood pressures from left to right of a great nature, typically greater than 10 millimeters of mercury, up to 30 millimeters of mercury, would indicate a pipe problem. So the left side is supposed to be equal to the right side because it's a closed system. The reasons that that would not be true is if you think of aneurysm. Well, you've added space to the pipes that wasn't supposed to be there. So that makes sense that now there's a difference in left to right pressures. What about if you have a big blood clot in your left leg versus your right leg? Then that would show a great difference between left blood pressures and right blood pressures. They're not supposed to be grossly different. So that is the conversation of pulse pressure. If you hear us talking about pulse pressure, that's what we're talking about. We're talking about the fact that it's supposed to play together. And if it's not, it's diagnostic. So as we get into the medical module, we'll take pulse pressure and we'll apply it to the things you can find out about from pulse pressure. Okay? Remembering that blood goes all the way into our capillaries, and that makes capillary refill. If you squeeze the nail bed of your index finger, it turns white, and if you let it go, it quickly fills back in red. It should be less than 2 seconds. That would be a normal capillary refill, and that means that everybody's playing well. You are systemically vascular resistant SVR. SVR, systemic vascular resistance, which you're going to see in this chapter, is the true way to say blood pressure. Blood pressure is a layman's term. The real way you talk about blood pressure is systemic vascular resistance. How much resistance in the pipes does the left ventricle have to squeeze against? When the left ventricle goes into systole, it squeezes. The pipes are too squeezing. The difference in that resistance equals your blood pressure. Your systolic blood pressure comes from the resistance that the left ventricle meets in the pipes. If that doesn't make sense, speak up. We already know this. So what are the nutrients that we need? We need oxygen, sugar, and enough fluids to keep the pipes able to squeeze and to remove waste, right? Those are very common, known things. Again, we look at, is this a ventilation oxygenation emergency? Or is this a pump failure, pipe failure, or fluid failure? So, what goes wrong with the pump? You need to look at these slides. What is the threshold for being a problem in the differing blood pressure across the limbs? Typically, we don't want them to be greater than 10 millimeters of mercury from left to right. Example, if you took a blood pressure in the left arm, it should be 128. And if you took a blood pressure in the right arm, it should be 138 to 118. So up and down by 10. So if you had 154 over 90 in the left arm and you had 108 over 74 in the right arm, that would be cause for great concern. And we're talking about reliable pressures, a person who is sitting still, a person who's not talking, a person who's in the same position that you took on the left side, that position should remain for the right side. If that's true, there should not be gross differences between the left and right. In fact, the American Heart Association put out a large article to show that people who do maintain chronic differences from left to right systemic vascular resistance, also known as blood pressure, have a higher chance of mortality via stroke, heart attack, and other comorbidities like high blood pressure, aneurysms, vascular disease. So those numbers are very real. At the 5-year, 10-year, and 15 to 20-year mark, you can see the data start to increase in those who do share difference from left to right. Pump failure. What are the shocks that come to the pump? And the main obvious one would be a heart attack. A heart attack is a direct failure of the pump because it isn't being fed any oxygen, so it fails, right? So a heart attack would be the best pump failure example. Low fluid volume. We call the fluid volemia. Isn't that easy? Because volemia is volume. So if you had hypovolemia, you've got too little volume. Now there's two big ways to be hypovolemic. Blood loss and hydration loss. If a person persists for greater than 72 hours with diarrhea and vomiting without replacement, they run a risk of hypovolemia. You don't just need blood. You don't just need red blood cells, white blood cells, platelets. You also need the plasma, or those plate cells, those actual physical cells don't go anywhere. They float in fluid and are distributed throughout the body in that fluid. You can have all the cells of blood you want, but if you don't have enough plasma, you can't get it anywhere. So if you lose all your hydration, you've been vomiting and had diarrhea for multiple days without replacement, you'll die because you can't get the oxygenated red blood cells to each individual cell of your body. You will die from hypovolemia. That's a version of shock. So when you think about volume shock, when you think about the fluid, you think about blood loss, which is easy, and you think about vomiting and diarrhea. You think about someone who has been running a marathon but not replacing. Okay? let's go to vessel shock. This one's a little more intense. Distributive shock, also known as pipe shock, is when the pipes won't squeeze. The pipes are supposed to squeeze. When you sit up, they squeeze. When you stand up, they squeeze. When you sit down, they relax a little. When you move your body, they're constantly squeezing. If they fail to squeeze, you'll die. There's no amount of heart pumping and no amount of volume that will keep you from dying if your pipes will not squeeze. So we call pipe shock distributive shock because the pipe's job is to squeeze appropriately so that the fluid is distributed throughout the body. The ways the pipes fail are from sepsis. Sepsis causes the pipes to stop squeezing. Sepsis is a gross infection that makes its way to the bloodstream. I want you to know that there's a real word called gross, and it's not the one you used in second grade. Gross means on a macro scale. It means on a large scale. It means broadly affecting. So if you have an infection that is so unmanaged by the body's immune system or medical care that it makes it into the bloodstream and overwhelms the person, they will stop squeezing their pipes. We could get into the reasons why, but I'm going to leave that alone. But they will stop squeezing their pipes. So severe infections are distributive shock. Anaphylaxis. That's supposed to have an S on the end of it. Is another distributive shock. Your body is overwhelmed by a histamine response, an allergy response, and loses the ability to squeeze the pipes. So again, you have all the same blood. The blood didn't go anywhere. The hydration didn't go anywhere. The volemia is the same. The pump is pumping like hell. It's doing everything it can to make up the difference. But you're not squeezing the pipes. So then you have no blood pressure. The patient's super diaphoretic. They're pale as shit. And they're dying from pipe failure. Distributive shock. So a heart problem is cardiogenic. Fluid is volume-based hypovolemia shock. And vessel shock or pipe shock is distributive because their job is to distribute the blood. Make sure you can give examples. Heart attack, cardiogenic. Anaphylaxis, distributive. Sepsis, distributive. Trauma, hypovolemia. Dehydration, hypovolemia. Vomiting and diarrhea, hypovolemia. Know what the categories of shock are and who gets put in that category. You have cardiogenic shock. You have distributive shock. You have volume-based shock. And then you have the weird one, obstructive shock. And it means exactly what it sounds like it means. You have obstructed the ability to move the blood volume. So, pulmonary embolus would be an obstruction. The heart's pumping, the pipes are squeezing, the blood is still the same amount, but it can't go round and round because there's something blocking the highway. So that would be an obstructive shock. Pneumothorax. If you drop one of your lungs and you increase all the pressure inside your chest cavity to work against the heart and work against the lungs, and it squeezes them so much that they cannot mechanically move, then they have been obstructed. So it would be an obstructive shock. Your categories are cardiogenic, volume, distributive, and obstructive. Be able to name the 4 categories. Be able to list what causes, what diagnoses go in each category. The last one is a little bit of a crazy one. It does not do what the rest of the shocks do. It's neurogenic shock. And in order to explain neurogenic shock, I will explain what normal shock looks like. On your note-taking material, I want you to make a little section that says early signs of shock. And then below that, make a little section that says late signs of shock. Because in order to understand why neurogenic is weird, in order to understand why it does not follow the rules, you got to know the rules. If you were to encounter an obstructive shock, a cardiogenic shock, a volemic shock, a distributive shock, you would show the same early signs of shock, which are anxiety and impending doom. The patient's brain knows they're in trouble. They know that they're in shock. They become very anxious. They become very emotional. They become hard to control, even. The next sign that's really early is tachypnea, breathing fast. The next sign is tachycardia, fast heart rate. The next things you'll witness is a change in color, temperature, and condition of the skin. Most importantly, the skin becomes pale and diaphoretic. We remember that diaphoresis is the wetness of the skin, profuse sweating. Diaphoretic means to sweat. If you notice, everything I just listed for you as early signs of shock occur in the primary, and they did not require any Mac Daddy equipment. They didn't require a cardiac monitor. They don't require a paramedic. They don't require a doctor. They don't require fancy machines. They require you simply looking, feeling, listening to your patient. First thing that happens to people when they go into those types of shock is a mental status change. Immediately with tachypnea, tachycardia, and skin changes. Those are early signs of shock. We call the early signs of shock compensation. Compensation. Compensation is that anxiety/impending doom. Compensation is tachypnea. There's supposed to be an H in that. Compensation is tachycardia. Compensation is skin, temp, color, and condition change. All of those things say, I am fighting to survive. Compensate, compensate, compensate. If you were to have a cardiogenic shock, the pump says pump harder. The volume says I need to move faster. The vessels say squeeze harder. Everyone that isn't broken starts trying to pick up the slack of whatever is. That is the normal process of shock, compensation. If a person is found early enough in any emergency, you are going to see a sign of compensation. Sufficing that you're looking for it, that you are assessing the patient. Decompensation are late signs of shock, and they mean that we have missed the ball. Late signs of shock include low blood pressure. Everyone wants to know what is the blood pressure? What is the blood? It's too late. To know the blood pressure is bad is too late, because that is a later sign of shock. Semi to unconsciousness. Too late. Cyanosis is almost always a late sign, waiting for them to turn blue. They're behind the ball. That's decompensated. Those are late signs. SpO2. SpO2 changes take anywhere from 5 to 15 minutes, depending on the condition and the reasoning, the mechanism, the why. So if you want to catch people in early shock, compensated shock, you got to be looking for the primary assessment findings. If you wait until you see bad blood pressures, unconsciousness, semi-consciousness, cyanosis, low SpO2, low end in titles, that stuff is late, and it means we didn't catch this early enough to make the biggest impact on a favorable outcome. Okay? So, you now know what normal compensation looks like in the typical shocks: cardiogenic, volemic, obstructive, and distributive. You know what compensation looks like, and you know what decompensation looks like. You know why the vital signs that are in the secondary assessment on the sheet, when you look on the sheet, and all this time you've been wondering, why the hell don't we take blood pressures faster? Because they're late. They're late to the game. It's great to know, but it only helps you reinforce what you know. It is not an early sign. It's not a great indicator of the fastest version of the body's compensation. That's why it occurs in the secondary, not in the primary. You're going to see test questions that merely give you an example of symptoms from the patient, signs from the patient, and they're going to simply ask you which one of these are early, which one of these are late. Be able to choose. They're going to ask you, what type of shock is anaphylaxis? It's distributive. They're going to ask you, why is cyanosis not a great thing to look for in shock? And the answer is because it's such a late sign. It takes too long to show us that the patient is in trouble. Okay? So then let's go back to what opened the door to that conversation. Let's go to neurogenic shock. And let's look at why neurogenic, I called it weird. I said it doesn't like to play by the rules. When you go into shock, your brain releases chemicals that make the compensation happen. That's how we see the anxiety, the impending doom, the tachypnea, the tachycardia, the skin changes. That's how we see it. Because the body released epinephrine and norepinephrine and started fight or flight, which is the sympathetic system, we saw that because the brain knew there was a problem and released those chemicals. Well, in neurogenic shock, the brain itself has been insulted. It has been injured. So it doesn't remember to tell the rest of the body that there's a problem. So the shock looks very different in neurogenic. And that is how you will identify it. You will identify neurogenic shock by becoming so familiar with normal-looking compensated shock. You will become so familiar that compensation looks like anxiety, impending doom, frustrated mental status, combativeness, a very hyper-mental status. Tachypnea, tachycardia, skin changes. That's what shock looks like. Then you'll get a neuroshock patient, and you'll be like, why? I can see this patient has had a significant mechanism. They dove off of the roof trying to get into the swimming pool. They didn't quite make it. They hit the cement head first. So they have this significant external mechanism. But when you go to put them on your vital signs, they all look fine. Their breathing rate is 12. Their heart rate is 60. Their blood pressure is 110/50. So if you're thinking about what shock normally looks like, if they were in normal shock, they'd be breathing fast. They'd have a higher heart rate. They'd have a blood pressure that might be higher because it's trying to compensate. But here, in the neurogenic patient that dove off of the ceiling and didn't make the pool, they hit the cement instead, their brain has been insulted, and it's not telling the body, release those chemicals. It's not saying to the body, we need to compensate. And here's the bad part. It stops releasing those chemicals at all, and the heart rate will keep going down. The breathing rate will keep being erratic. Breathe fast, breathe slow, don't breathe at all. The blood pressure will continue to fall until there's no heart rate, and there's no blood pressure, and there's no breathing. The way you spot neurogenic shock is by recognizing that the body is not acting the way it should based on the mechanism you're looking at. This patient should be showing me signs of shock and they're not. That's what you should be attending to. That's what should shock you. It's what should say, oh my, there's a problem. In neurogenic shock patients, you see low heart rates. In neurogenic shock patients, you see low blood pressure. In neurogenic shock patients, you see rapidly changing respiratory patterns. It does not play or act like any of the other shocks. And that is how you spot it. I have a mechanism. The patient should be compensating. They're not. That's neurogenic shock, and it's because the brain has been insulted and it's no longer awake enough. It is no longer functioning enough to make the chemicals happen that provide for compensation. Any questions about that? What is the time frame to go from early to late signs of normal shock? So this is a question you guys ask a lot, because wouldn't it be easy if we could actually find a data point that says a person sits in shock in this particular condition for this long? Well, that doesn't happen, Zach. We didn't get it that easy. That's why they call it the practice of medicine. And that doesn't happen. So the answer to your question is, we don't know how long they were in one or the other, and it is based on what your cause of shock is. Let me give an example. If you have a significant pneumothorax, your compensation period might be less than 5 minutes before you immediately die. That's because the type of shock you had, the obstructive shock that you had, is so overwhelming and is so significant that you died before you had a chance to show significant compensation. Now, if you can catch them in that 5 minutes, I bet their blood pressure is almost nowhere. It's probably almost not readable. Their heart rate's probably 180, 190, 200. Their respirations are probably 60, 70, because they're doing everything they can to try to live, but you can't. So the answer is there is no set time frame for how long a person will compensate, how long we'll see one stage of shock versus the next stage of shock. The answer is it depends what caused the shock. We call that etiology. Etiology is the origin of something. So some shocks give us time. Some shocks don't. That's why we came up with the EMT scope, the advanced scope, the paramedic scope. The answer to why you guys are able to do most of the skills you're able to do is simply because those are the things that will kill people the fastest. Those are the shock phases that occur the fastest and are the most detrimental. We think anaphylaxis. We think not breathing, no pulse. We think bleeding out. There's no time for compensation in those most aggressive emergencies. So then that time frame is grossly variant to what caused it. With sepsis, you've got this very long time frame where if you're looking, you're going to find it. If you were trying at all, it's there. You know, I think of a heart attack patient. Well, they start with mild chest pain and that pain grows. They give you, typically speaking, they give you time to find that compensation, find the shock, and then treat that patient emergently and get them to the place that will definitively solve whatever it is that caused their problem. Does that make sense, Zach? Very good question. And it makes me know that you're listening, because if you are able to hear that these are the signs, the next thing you want to know is, well, how long do I have? How long do I have to find this? And unfortunately, it's not that easy for us. So that's why it's important to know. It's not important to take the damn test. Who cares what you can score on the test? What's important is that you realize that if you are seeing low blood pressure, then the shock has been happening for some time. We're in trouble. If you're seeing cyanosis, all the good stuff where you could make the biggest impact, that's all behind us. We're in trouble. That is what is important when it comes to understanding shock. Your entire job as an EMT is to find shock the fastest and earliest possible time frame from the point of the mechanism. Whether that's a medical cause or a traumatic cause, our job is to spot it as early as possible, because the earlier, the more intervention time we have. In fact, you can look at multiple different causes of shock, and there are actually statistical data to how long it should take us to resolve that problem before the patient will probably die. In the United States of America, the American Heart Association has set the door-to-balloon time for heart attack patients to 90 minutes. They believe that if you block one of your coronary arteries, so much so that the heart begins to die from a lack of oxygen, that you have about 90 minutes to open that artery up and make it start having oxygen flow through again before irreparable and permanent damage occurs, and the patient is likely to, 1, have extreme heart failure, and 2, die. So there are some numbers out there. The general understanding is that we've got to find it as early as we can find it to give the patient the best the best outcome. An example of that being trauma patients. We call trauma patients the golden hour patients, because the data says that from the very point of injury until they get onto an operating table to correct the massive damage, if that is more than 1 hour, their chances of mortality and morbidity and chronic outcome, unfavorable chronic outcome, goes through the roof. So then we have to find it as early as possible. All right? So here's a slideshow, kind of a little cheat sheet of what we already discussed. Okay? So you got heart attacks that fall under cardiogenic, and then pneumo, cardiac tamponade, pulmonary embolus, that's all obstructive. So tension pneumothorax just means the lung has failed, it dropped, and there's air or fluid pushing everything in there closed. Cardiac tamponade means the same thing, but in a different way. It means the heart cannot squeeze, but it's because the sac around it is full of fluid, blood, pus. For whatever reason, the sac around the heart, the pericardium, is squeezing it so tight that it can't beat anymore. That would be obstructive shock. You're going to learn about later why that would happen, how to spot it, what would it look like if it happened, what mechanisms would cause it to occur. We're going to learn about that. All right, talked about all of this. Of course, you're going to read through this chapter, arguably a foundation-based chapter of you understanding the rest of this entire class comes from this lecture, this chapter, your research into this material. All right, let's talk about what we do if we find shock. If you're looking at your National Registry sheet, you find us in the primary, right? And the primary is where we found all the magic. The mental status change, the tachypnea, the tachycardia, the skin color, temperature, and condition changes. That's where we found it. So what do we do? If you look on the sheet, the next option after C is determine the patient's priority. Okay? I found these things. I'm going to say the patient is exhibiting signs of shock. This is going to be an emergent priority, and I'm going to treat the patient for shock. That's an intervention set. Treat for shock. If you go over the encode radio, hold on 2 seconds. I had to come back to you. Does everybody have me? Everybody listening? You can hear me? Hands up if you can. Okay, good. Thank you. I had to reset. So, as I was saying, if you found these things in the primary, then we have to treat for shock. Treating for shock is an intervention set. If you were to come over the radio to the doctor and say, we're treating the patient for shock, that actually means you have done a certain amount of things. Let's go through what those things are. High flow oxygen. So that's 15 liters from whatever device you come from. No matter what you're doing, whether that's bag valve masking or whether that's a non-rebreather, whether that's CPAP and BiPAP, it means you're treating with high flow, 15 liters. Blankets, because people that go into shock lose their ability to control their body temperature. We know that becoming cold causes a lot of bad things to happen in the patient. We know that it contributes to things we call the diamond of traumatic death. When you become cold, you're no longer able to clot blood correctly. You're no longer able to maintain your pH balance, your acidosis versus buffer system. That's what happens when you get cold. If you lose those abilities, we don't see that in our setting. The patient dies from that days from now. So we're not just treating the patient for what we see in front of our face, we're also preparing the patient for the fight that they will take to get out of this emergency for the days to come. Never let anyone tell you that what you're doing in the back of the ambulance is simply because of what applies to the pre-hospital setting. We're not treating the patient just under an EMS ideology. We're treating the patient as to what statistically shows favorable outcomes to the end of their emergency. We call that definitive resolve. What are we going to do in our setting that betters the chance the patient doesn't die later, doesn't die now, doesn't go home a different person than they were before this happened, doesn't have to go on hospice, doesn't have to go to rehab for 2 months? That's the stuff we're doing in the back of the ambulance. So that blanket may not be for today. It may be what is protecting the patient from their shock symptomologies even tomorrow and the next few days and the weeks to come. And then appropriate positioning. You put patients in physical positions that assist their blood pressure, that assist oxygenation, that assist with mental status control of the patient. If a person's blood pressure is low and they have no airway concern, they should be supine. Because the heart doesn't have to work as hard, the pipes don't have to squeeze as hard, there doesn't have to be that amount of blood as much as normal to get oxygen to all the tissues. That's the thought process. So if I lay them supine, they're not working as hard to feed oxygen to the brain, to the lungs, to the heart, to the kidneys. So wherever you put the patient, whatever position you put them in, matters. If the patient has an airway concern, they need to be in semi-Fowlers to Fowlers. If they have a blood pressure concern with no airway involvement, they need to be supine. Hold on.
You are now muted.
Regional is large to Medical University, South Carolina, Charleston. Anyway, the check. Patient weight is 180 pounds, 108 pounds. At 13 okay.
You are now unmuted.
So that is the treatment of shock. High flow oxygen, blankets to protect warmth, and you choosing a position that is best for the patient based on what we just discussed, whether there is airway involvement, whether there's a mental status involvement, or whether this is just low blood pressure. Okay? All right, I have a flight. That was pretty much the end of this lecture anyways. So now you know how to identify shock. Now you know the stages of shock. Now you know the categories of shock. Now you know how to treat for shock, most of which is found in the primary. So I'm going to let you read through the rest of the chapter. I'm going to let you do the homework. That is the material to be discussed in the lecture, and it will conclude our lecture. I'll check you guys out on the sheet when I come back. Is semi-Fowlers or Fowlers determine patient comfort? If the patient is not exhibiting significant signs of shock, Zach, then yes, patient comfort would be okay. But if the patient is emergent, then we should choose a position that benefits them based on their shock. So if they're conscious and have a good airway, then I'd lay them supine. If I'm worried about their airway and I still need them supine, maybe I choose the recovery position. As we go on through class, we're going to talk about choosing positions based on the shock of our patient. Okay? All right, I'll let you read the slides at the end of the chapter. That will conclude our lecture for today. Love you guys. I'm going on a flight. Wish me well. Y'all be safe. I'll see you Wednesday.